Hey, before we start the video, if you like this sort of content and you want more, come check out Med School Bootcamp. We have content for Step 1, Step 2, Anatomy, and OMM. Right now, we're about to watch the Biochemistry section. And if you're looking for downloadable PDFs, along with shorter videos and quizzes after each video to help you reinforce the information, then you can find it all on Med School Bootcamp. We also have a Step 1 question bank with some of the most representative questions to help you prepare for Step 1. You can also create a custom Step 1 study schedule when it's time for dedicated. So if you're looking to crush it in med school this year and pass Step 1, come check out Med School Bootcamp. It's going to be your first link down in the description. Now on to the video.
Hi everyone, my name is Paige and thank you so much for joining me for our chapter on vitamins. If you've been watching the Biochem series chronologically, congratulations, you have made it to the last chapter. Now there are a lot of vitamins to cover, but the good news is you've seen all of these vitamins before at work throughout the biochemistry unit. And so this chapter is mostly going to be a fond walk through memory lane as we recap some of the important pathways that all of these different vitamins are in. This video is going to be an introduction to vitamins, both the fat-soluble and the water-soluble vitamins, comparing and contrasting those two groups, and then we'll get into the spotlight profiles, first of the fat-soluble and then of the water-soluble vitamins. We'll finish off the chapter by talking about trace elements, which don't quite count as vitamins, but they are still important to know for your exam. So let's get started with our introduction to vitamins. So what even are vitamins? Vitamins are micronutrients that do not provide energy. So a big portion of the biochemistry unit was focused on macronutrients, where we do derive energy, like carbs, protein, fats. So vitamins are not an energy source the way that those macronutrients are. However, they're going to participate in those energy production pathways in other ways. And we've seen the vitamins at work throughout these pathways, doing their work as coenzymes, functioning in cell signaling, gene transcription, and with antioxidant properties. And there's two big categories of vitamins. There are the fat-soluble vitamins, and there are the water-soluble vitamins. The fat-soluble vitamins are vitamins A, D, E, and K, and the water-soluble vitamins are all the B vitamins and vitamin C. The water-soluble vitamins like to be in the C, vitamins B and C for water soluble. We'll start by talking about the fat-soluble vitamins, and as their classification name suggests, these require fat to be absorbed. If you remember back to our lipid absorption and digestion series, you'll remember that lipids were absorbed in the form of chylomicrons, and those fat-soluble vitamins were also packed inside those chylomicrons. What this means is that in order to have adequate intake of fat-soluble vitamins, lipid absorption must be intact in the body. And now the fat solubility of these vitamins also means that they can be stored in the body for long periods of time. Now, by and large, dietary absorption is the largest way that we get our source of fat-soluble vitamins. But for the sake of accuracy, there are a couple of exceptions, namely that vitamin D can also be synthesized within the body, and we'll talk all about that in our vitamin D video. And additionally, some vitamin K can be synthesized by gut bacteria. The primary functions of the fat-soluble vitamins are going to be in signaling, transcription, and oxidative stress. And each one of these vitamins has a different combination of these functions. Now, because these fat-soluble vitamins, like we said, do require fat in order to be absorbed, a lack of fat absorption is going to lead to a lack of fat-soluble vitamins. So you can become deficient in vitamins A, D, E, and K in processes like malnutrition or fat malabsorption. And this can be pathologic or it can be iatrogenic. From a pathologic standpoint, we might be thinking about causes of steatorrhea, like cystic fibrosis or celiac disease, or any cause of bile acid malabsorption, but there are also medications like orlistat or mineral oil that can also cause this. And then, like we said, the fat solubility of these vitamins means that they can be stored in the body. But the other side of that coin is that these fat-soluble vitamins will cause toxicity with overconsumption. Now let's take all that and contrast that to the water-soluble vitamins. The water-soluble vitamins are not coupled to lipid absorption. Instead, they are absorbed via their own designated intestinal transporters. And most of the water-soluble vitamins are not going to be stored in your body. They'll be renally excreted. The exception is vitamin B9 and B12, which will be stored in the liver. The water-soluble vitamins have a lot of similar functions to the fat-soluble vitamins, although each vitamin has their own subset of pathways that they are involved in. But these have functions as coenzymes and coenzyme precursors and antioxidants. And like we said, your body doesn't hold a lot of stores of these water-soluble vitamins. So you can become deficient with diet restriction. A vegan diet is something that they'll very commonly test to prompt you for something like this, or from malabsorption, and that malabsorption malabsorption can be pathologic with something like a pernicious anemia, or iatrogenic, like if someone has had a Roux-en-Y bypass. Like we said, most of these are renally excreted, and so toxicity is going to be pretty rare from the water-soluble vitamins. Water-soluble vitamin toxicity is possible, but you're mostly going to see it in the water-soluble vitamins that we are administering therapeutically in very large doses. Things like B3, B6, and the C vitamins. So let's wrap this up. This was a quick compare and contrast between the fat-soluble and the water-soluble vitamins. Like we said, all vitamins are micronutrients that do not provide energy. Instead, they have various other supportive roles in the biochemistry pathways we've been talking about this unit. Our fat-soluble vitamins are vitamins A, D, E, and K, where our water-soluble vitamins are the B vitamins and vitamin C. Our fat-soluble vitamins are coupled to lipid absorption and are stored in the body. As such, they can become deficient in cases of malnutrition or fat malabsorption. And because they are stored in the body, they pose a risk for toxicity with overconsumption. Our water-soluble vitamins are absorbed in the intestine via their own transporters, and most are not stored in the body. You'll get deficiency with diet restriction or with malabsorption through these designated transporters. And like we said, toxicity is rare because these are excreted renally, the exception being where we are administering vitamins therapeutically at high doses. Let's move on now to our spotlight profiles of each vitamin. Till then, that's all I got for you. Good job, good luck, and keep practicing.
Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin A. Vitamin A is the first fat-soluble vitamin that we'll be talking about, and it is in a class of molecules called retinoids. And the active form of vitamin A is called retinol, and retinol has functions in vision, transcription, cell differentiation, and it also has antioxidant properties. As you can see, vitamin A is very high yield. It is a pet favorite of the NBME for the USMLE exams. Before we start getting into all of the functions and clinical implications of vitamin A, it's important to understand its synthetic pathway, if for no other reason than to understand the sort of complicated, similar sounding verbiage that goes on when we're talking about vitamin A. So retinol, or the active form of vitamin A, can either be derived from yellow or leafy plant sources or from animal organs. When it comes from a plant source, it is in the inactive provitamin or carotenoid form. When it comes from animal organs, it is in the storage or retinyl ester form. So here's our diagram of the vitamin A synthetic pathway, and don't memorize any of these structures. And so here you can see retinol, which is the classic active form of vitamin A that we're mostly talking about in this video. There is another active form of vitamin A called retinoic acid, which we'll talk about in a little bit. And so it's important to understand not only vitamin A proper, but also the derivatives of vitamin A. And so like we said, we can derive vitamin A from two storage sources, either from plants and leafy greens, and that's in the form of a carotenoid. The carotenoid that might be coming to mind for you, if you've heard of these before, is beta-carotene, which is famously what gives carrots its orange color. And our other starting point, remember, was with animal organs. You can see my little liver drawing down here. And when you're starting with those, that is the retinyl ester form. Let's start up top with the carotenoid form, like beta-carotene. And you can see that this beta-carotene is this big, long molecule, but it is symmetrical. So the first thing we're going to do is we're going to split it right down the middle, and we're going to form two retinaldehydes. Right, here's one, and here's the other. And it's an aldehyde because of this group right here that gets put on in the cleavage reaction. I will spare you from those details. Now, this aldehyde group can participate in one of two reactions. It can be oxidized or it can be reduced. If we were to oxidize it, we would add another bond to oxygen right there and turn it into retinoic acid with this carboxylic acid group on the end. So retinoic acid is also an active form. It is an active vitamin A derivative, even though it is not retinol itself. We'll talk about some of the functions of retinoic acid in a little bit. But if instead of oxidizing this retinaldehyde, we reduce it, instead of adding a bond to oxygen, we will remove a bond to oxygen, and we will just be left with this alcohol group on the end, and that is our retinol, our active form of classic vitamin A. Now, this oxidation reaction that turns retinaldehyde into retinoic acid is effectively irreversible. The reverse reaction is really not significant in any meaningful way. And this reduction reaction that turns retinaldehyde into retinol is reversible. And then the last piece of this puzzle here, if instead of starting with beta-carotene and with plants, we were to start with animals and their storage form of vitamin A, which is retinyl ester, right? That's the form that you're going to store your vitamin A in your body too. We would just break off that R group off of the ester, and that would give us our active retinol. And when we store vitamin A in our body, we just run the reverse reaction. All right, so let's take it back to the outline. If we were starting with the carotenoid or plant form, we could split that down the middle into two retinaldehyde molecules. Now, if you didn't think that the nomenclature could get any more frustrating, retinaldehyde can also be called retinal, but when people say it, it can sometimes sound like they're saying retinol. So they read and sound alike, just be careful. The AL is the aldehyde. And that retinaldehyde, remember, had a choice. It could either be reduced into retinol, and that was a reversible reaction, or it could be oxidized and turn into retinoic acid, and that was an irreversible reaction. And that retinol could be esterified to a long-chain fatty acid form in the liver, turn into that retinyl ester. And that retinyl ester could be stored in the hepatic stellate cells. All right, enough pathway stuff. Let's move now into the functions of vitamin A. The big one that you've probably been told since you were a kid when your parents told you to eat carrots because they're good for your eyes is that vitamin A is good for vision. This is because it makes up a component of rhodopsin, which is a light-activated pigment in the rods of your eyes. You can see the name of this component here, 11-cis-retinal. Should be no surprise to you that a vitamin with all of this retina-related word roots would be implicated in the retina. Another function of vitamin A and its derivatives is gene transcription. And especially to know is gene transcription via all-trans retinoic acid, or ATRA. Just meaning that all these double bonds down here in the retinoic acid are all in the trans configuration. All-trans retinoic acid is going to bind to nuclear receptors, and you might see names like RAR and RXR floating around when you're reading about this stuff. And when the ATRA binds, it will cause uncoiling of chromatin, which will expose promoter regions on genes. As such, right, altering gene transcription. And then another big function of our retinoids, which is just what we call all this family of all this stuff down here, are functions in cell differentiation. Specifically, retinoic acid promotes epithelial differentiation and specialization and can prevent squamous metaplasia. And that's why you'll see retinoids involved in all sorts of anti-aging skincare products, acne treatments, things like that we'll get into in a little bit. So let's talk now about vitamin A deficiency. This is a fat-soluble vitamin, like we said, so it's going to be caused by malnutrition or fat malabsorption. Like we said, vitamin A is very involved in the eye, and so as you would imagine, there are going to be lots of ocular manifestations of a deficiency. Things like retinopathy, night blindness, remember like we said, it's involved specifically in rhodopsin in the rods, xerophthalmia, which is dry eyes, and keratomalacia. One manifestation of this is Bitot spots. If we zoom in on our picture here, you can see a Bitot spot. So a Bitot spot is usually on the bulbar conjunctiva, and it's this gray, foamy looking triangular patch. And it's caused by squamous cell metaplasia and abnormal keratinization of the conjunctiva. Like we said, remember, vitamin A is protective against squamous cell metaplasia. So this is what happens when you are deficient. This is an image that should be a standalone, don't need a vignette image for you. Frequently in vignettes, they'll give you very little information. They might give you one or two risk factors for a vitamin A deficiency, like the patient appears malnourished or has housing insecurity or something like that. And then they'll say on physical exam, you see the findings in the image, and they'll just give you this. And that should be all the information you need to diagnose a vitamin A deficiency. Other non-ocular things that you might see with a vitamin A deficiency include squamous metaplasia of the bladder. And so on cystoscopy, they might describe pearl-like plaques to describe that squamous metaplasia, xerosis cutis, which is just dry skin, growth inhibition, and immunosuppression. And one way that they test that immunosuppression thing specifically is with measles. It's a poor prognostic indicator to be vitamin A deficient if you have the measles, and we'll talk about that too in a little bit. So let's switch gears and talk about vitamin A toxicity, which, like we said, because vitamin A is fat-soluble, we can get a toxic buildup. Toxicity is going to be caused by supplementation, medications, or increased consumption of organ meat like liver. And sometimes they can have fun with those vignettes, and it'll be a bodybuilder who's on an all red meat diet or something like that. We can think about the effects of vitamin A toxicity as acute, chronic, or teratogenic. Acute vitamin A toxicity is going to present with nausea and vomiting, vertigo, blurry vision, and headache. Unfortunately, not very specific, so you are looking for those key history pieces that we talked about. Chronic vitamin A toxicity looks a lot different. There you're going to see arthralgia, alopecia, scaling skin, hepatotoxicity, And you can also see idiopathic intracranial hypertension, IIH, formerly known as pseudotumor cerebri. And those symptoms might make a little more sense based on the functions of vitamin A that we were talking about before. Now, unfortunately, vitamin A is extremely teratogenic, and we'll talk about that a little more in a second when we talk about the therapeutic uses of vitamin A. But vitamin A as a teratogen is devastating to the fetus. It'll cause microcephaly, microphthalmia, cleft palate, thymic agenesis, cardiac and neurological abnormalities. And so that brings us into our therapeutic uses of vitamin A. The big one is isotretinoin, which is the staple of cystic acne treatment. Isotretinoin, also known as 13-cis-retinoic acid, which remember we said promotes epithelial differentiation and specialization, is going to do just that as a therapy. It is going to treat severe cystic acne by promoting epithelial differentiation. This is a high-yield mechanism, and this is a high-yield medication for cystic acne. It's another type of question where they love to give you an image. They'll give you an image of somebody with really painful-looking cystic acne and ask you what you want to do. Isotretinoin is always a safe bet. But you must be careful because, like we said, vitamin A, and therefore isotretinoin, which is very potent, is extremely teratogenic. So before you prescribe isotretinoin, you have to enroll patients in the iPledge program. And it's a whole thing, but at the core of the iPledge program is that patients must be on 2 forms of birth control due to just how devastating that teratogenicity is. Next therapeutic use of vitamin A and the retinoids is measles. Like we said, a vitamin A deficiency is a poor prognostic factor. So vitamin A is supplemented in patients with measles. It is just for the morbidity and mortality benefit, improving that immune system. And the final therapeutic use of a retinoid, again, this time we've got all-trans retinoic acid, is going to be in the treatment of APML, acute promyelocytic leukemia. APML is caused by a translocation between chromosomes 15 and 17, which creates the PML-RARA gene, which is a fusion gene that stands for promyelocytic leukemia retinoic acid receptor alpha. That retinoic acid receptor, right, that RAR, is what we saw before above. Remember, all trans retinoic acid binds to that RAR, and so we can use our all trans retinoic acid to target those malignant promyelocytes that have that malignant fusion retinoic acid receptor. So acute promyelocytic leukemia, APML, is the only cancer that we can treat with a vitamin. We treat it with vitamin A. It's the all-trans retinoic acid, which is, a retinoid. That should be crazy to you that we can do that. And it's crazy to the test writers, too, because they love to test it. This comes up all the time. No APML in and out, and know that you use all-trans retinoic acid to treat it. They're going to test it in a million different ways, whether you can identify it, whether you know how to treat it. It showed up on step 1, it showed up on step 2, it follows you forever. Know this for sure. So let's wrap this up. We've been talking about vitamin A, retinol, but really more broadly, we've been talking about the molecule class of retinoids. Vitamin A was derived either from yellow leafy plant sources, from the carotenoid form of retinoids, or from animal organs from the storage retinyl ester form. We had 2 big active forms of vitamin A. We had our retinol, and then we also sort of had its cousin, which is retinoic acid. These molecules had implications in vision, gene transcription, via activity on nuclear receptors like RAR, and cell differentiation, where they promoted epithelial differentiation and specialization. We could use some of those functions therapeutically, like in isotretinoin to treat acne, or we could use all-trans retinoic acid and its activity on the nuclear receptor RAR to treat acute promyelocytic leukemia. We could also use it as part of the care for measles. When vitamin A was deficient, we would get lots of ocular manifestations, including Bitot spots and squamous metaplasia in other parts of the body, as well as some cutaneous findings like xerosis cutis or dry skin. Vitamin A toxicity could be acute, chronic, or teratogenic, with potentially devastating teratogenic effects. And that's why patients who are prescribed isotretinoin need to go on the iPledge program, where they are on 2 forms of birth control. We're going to keep on moving through our profiles of the fat-soluble vitamins. Till then, that's all I got for you. Good job, good luck, and keep practicing.
Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin D. Now before we jump into the video, I would encourage you to also check out the vitamin D video in the endocrine section. That'll be a really good companion piece to this video in understanding all of the implications of vitamin D. In this video, we'll talk about the biochemical synthetic pathway of vitamin D, and we'll talk a little bit about deficiency, toxicity, and therapeutic uses of vitamin D as well. So vitamin D is also called calciferol. It is a fat-soluble vitamin in the steroid class. And vitamin D is a vitamin that can actually function as a hormone once it's activated. And its job as a hormone is to promote the absorption of calcium and phosphate from both the GI tract and the kidneys, as well as enhance bone mineralization. And those ins and outs of vitamin D and its function are very high yield, so like I said, go check out the endocrine section for a full discussion. We are going to jump in and talk about the synthetic pathway, how we actually activate that vitamin D so that it can go do its job as a hormone with those functions. So let's zoom into our image. So here's our diagram of the vitamin D synthetic pathway. We're going to start by talking about our sources. We'll move through the metabolism and the activation pathway, and then we'll discuss a little bit the actual fates of vitamin D and what it goes on to do. So there are two major types of vitamin D. There's vitamin D2, or ergocalciferol, and vitamin D3, which is cholecalciferol. The D2 form of vitamin D that comes from plants, once you ingest it, can bind to this VDBP, which is the vitamin D binding protein, and that can travel through the blood and go to the liver for metabolism. Now, the other non-plant dietary sources of vitamin D are going to be in the form of vitamin D3, cholecalciferol. And this includes fish, dairy, and supplements. The vitamin D from these sources comes in the form of vitamin D3, which will bind to the vitamin D binding protein as well, go to the blood to the liver for metabolism in the same way. Only 20% of the vitamin D in your body comes from dietary sources. The other way that we get vitamin D, specifically vitamin D in the D3 form, is going to be from the skin. It's pretty interesting the way this works. So in your body, you start with provitamin D3, or the 7-dehydrocholesterol. Remember, like we said, vitamin D is in the steroid class, as is cholesterol. When the 7-dehydrocholesterol, or provitamin D, is met with UVB rays from the sun, it'll turn into a different form called previtamin D3. When that previtamin D3 is met with heat, again from the sun, it will isomerize and turn into vitamin D3. That's that same vitamin D3 that we got from these dietary sources over here. So it'll go through the blood and do the same thing, where it'll bind the VD binding protein and then make its way to the liver for metabolism. And so now, regardless of our source and regardless of whether it's D2 or D3, we have vitamin D in the liver ready for metabolism. And so we're going to start to think of all of these pathways as kind of merging at this step. The next step is a hydroxylation step with this enzyme here, 25-hydroxylase. This is in the liver, and it's going to turn our vitamin D into 25-hydroxy vitamin D. You can see here that we show that it's been hydroxylated one time at the 25 position. The other name for this is calcidiol. And this calcidiol is bound by the vitamin D binding protein, and it is the major circulating form of inactive vitamin D. So this is still not the active form, this calcidiol. The next step is the activating step. We're going to use another enzyme. This one is called 1-alpha-hydroxylase, and this is a very important enzyme that activates the calcidiol to calcitriol, doing so by adding a second hydroxyl group, now forming 1,25-dihydroxy vitamin D, calcitriol, and that's active. And this active vitamin D can go off to those tissues we were talking about before, like the kidney, the bones, and the gut, and it will increase calcium and phosphate in those target tissues. To finish off the circle of life of vitamin D, if we want to inactivate that previously active calcitriol, then we'll send it through this pathway here to be acted upon by this cytochrome P450 enzyme, which is CYP24A1 if you want to be particular, but I wouldn't memorize that. That will turn our active calcitriol into an inactive form. It's not the inactive form from over here. It's not the calcidiol. Instead, it is calcitroic acid. And that calcitroic acid can go to the biliary system and be excreted out. So that's what we do if we do not want vitamin D to be active anymore. So remember, like we said, two starting forms of vitamin D. There's vitamin D2 and vitamin D3. Vitamin D2, also called ergocalciferol, was from plants. Vitamin D3, or cholecalciferol, could either be synthesized in the skin with the help of UVB activation, or could come from animal products. The majority of vitamin D comes from the skin in the form of vitamin D3. It's only a minority, like 20%, that comes from the diet, and that can either be in the form of D2 or D3, like we just discussed. Then we got into a little more detail on that skin synthesis pathway. Specifically within the skin, this is happening in the stratum basale layer. We talked about how that 7-dehydrocholesterol, when met with UVB, becomes pre-vitamin D, which isomerizes into vitamin D3, as we've been discussing it, with heat. Once we established either D2 or D3, regardless of what kind it was, it would bind to the VDBP, the vitamin D binding protein, make its way to the liver to be hydroxylated via that enzyme 25-hydroxylase. That formed our calcidiol, or 25-hydroxy vitamin D, which was our major inactive form of vitamin D. To get to the active form, we had to do another hydroxylation with another enzyme. That enzyme was 1-alpha-hydroxylase, and that formed our calcitriol, or our 1,25-dihydroxy vitamin D. And that was our active form. Okay, so to understand the regulation of this pathway, for me, it's almost easiest to work backwards. So the point of vitamin D is to increase calcium and phosphate in the blood. It's promoting the reabsorption of these things from the kidneys and from the GI tract. So we are going to favor the active form of vitamin D when we are trying to increase calcium or increase phosphate. So then it makes sense that parathyroid hormone is going to increase the activity of 1-alpha-hydroxylase, right? It's going to promote the active form of vitamin D to increase calcium. So one of the end goals of parathyroid hormone is to increase serum calcium as well. Things get a little funky when you start thinking about the phosphate and vitamin D and parathyroid hormone have different effects on phosphate. Again, go check out the endocrine chapter. But at least in my mind, this is how I think about it. I prefer to think about the calcium. And then things that decrease 1-alpha-hydroxylase activity are going to be 1-calcitriol, right? This is going to act as its own negative feedback. Once we have enough calcitriol, we can turn off the pathway. And then also FGF23, fibroblast growth factor 23. FGF23 is a bone-derived hormone that acts to suppress phosphate reabsorption. Right? So the end goal of FGF23 is the exact opposite of the end goal of vitamin D, which is to increase phosphate. So therefore, they are acting at odds with each other, and FGF23 is going to downregulate 1-alpha-hydroxylase and disfavor active vitamin D. If you understand the regulation of the synthesis pathway of vitamin D, then you'll understand the regulation of the breakdown pathway of that active vitamin D, right? It's just the complete opposite. Parathyroid hormone promotes the formation of active vitamin D, so it is going to inhibit the breakdown of active vitamin D. Same thing that goes over here. These factors that inhibit the synthesis will promote the breakdown. So back to the outline, that 1-alpha-hydroxylase activity is going to be increased by parathyroid hormone, right, which is released when there is low serum calcium, and it will be decreased by FGF23, which is released when there is high serum phosphate. And then that calcitriol will also downregulate that 1-alpha-hydroxylase in a negative feedback loop. That calcitriol could go to target cells, be carried there by the vitamin D binding protein, and then whenever we're done with that calcitriol, it will be converted into the inactive waste form, calcitroic acid, and be excreted by the biliary system. And the formation of calcitroic acid, that waste form, is decreased by parathyroid hormone and increased by FGF23 and calcitriol, like we just discussed. Let's talk about vitamin D deficiency. Like we said, the majority of vitamin D is synthesized in the skin. So a decrease in UVB exposure, either from sunscreen or from an increase in melanin in darker skinned individuals, or just from not getting enough sun, these people will have decreased calcitriol because they don't have enough of that starting vitamin D3. Decreased calcitriol means decreased calcium and phosphate in the tissues, which are levels that the calcitriol was in charge of maintaining. Low calcium and low phosphate in the serum means disorders of bone mineralization. So there are two big disorders of bone mineralization that come from vitamin D deficiency. There's rickets and there's osteomalacia. The difference between rickets and osteomalacia osteomalacia is just whether or not the growth plate is closed. So rickets is defective bone mineralization in new bone. So this happens in children before the growth plate is closed. And there are lots of very classic findings and classic images associated with rickets that you must know for the STEP exam. The first ones are bowing of the long bones, right? Specifically bowing of the legs, or genu varum. So you can actually see curving and bowing of the bones themselves, or a change in that knee angle. The next thing you can see is distension of the bone cartilage junction. This presents in a couple ways. Classically, it presents with the ricketic rosary. And you can see this picture here. It's a beads on a string kind of appearance of the costochondral junction, the junction between the rib bones and the rib cartilage. And I'll erase it so you can see it, but it makes those beads right there. You can see this on the x-ray too, this beaded appearance of the costochondral junction. Another bone cartilage distension that you might see is called the Marfan sign. Unfortunate name for it. It has nothing to do, it's not like the thumb and wrist sign for Marfan disease or anything like that. The Marfan sign is a distension of the epiphyseal plate with widening and cupping of the metaphysis. Typically this affects the distal tibia, and it gives the sign of a double medial malleolus. So it looks like you have two medial ankle bone protrusions. And I don't have a picture of that, but I do have a picture of another example of cupping of the epiphyseal plate on this child's wrist here. And so you can imagine how this might look on an ankle. You sort of have the true medial malleolus, and then you have this like false medial malleolus right here. So we talked about the long bone bowing, the genu varum, the bone cartilage junction distension, like the ricketic rosary and the Marfan sign. Other things you can see include craniotabes, which is a softening of the frontal skull. They say when you press on the front of the skull of an infant who has craniotabes, it feels like depressing a ping pong ball, which is pretty vivid imagery. And then you can also see delayed fontanelle closure. All of these are very high yield for rickets. This is one of those ones that they want you to be able to diagnose based on clinical presentation. Other things you might see in rickets are symptoms of hypocalcemia. So tetany causing the Chvostek and Trousseau signs. Chvostek sign being when you tap on the cheek right in front of the ear of a patient with hypocalcemia, they'll have twitching of the facial muscles. And the Trousseau sign is a carpal spasm when a blood pressure cuff is inflated around the patient's arm. Other symptoms of hypocalcemia include paresthesias, spasms, and myalgia. So we said rickets is defective bone mineralization when the growth plate is still open. Osteomalacia is defective bone mineralization when the growth plate is closed. This is existing bone, and so this can happen in children whose growth plates are already closed or in adults. Usually they like to test rickets with children and osteomalacia with adults. You should know that that's technically not correct, although it's a pretty solid rule of thumb. Osteomalacia presents with bone pain, pathologic fractures, proximal myopathy, symptoms of hypocalcemia like we just talked about up there with the Chvostek and the Trousseau sign, and bone deformities. Similar to rickets, but not as stark. For vitamin D deficiency, on imaging, in addition to decreased bone density, you can also see something called pseudofractures, also called Looser zones. So if you see this transverse radiolucent band right here, right in the middle, I'll go right over it with my yellow, that is a pseudofracture or a Looser zone, and it represents an insufficiency stress fracture from vitamin D deficiency. And I'll take it off just so you can see, but it is that radiolucent band right in there. They're usually perpendicular to the periosteal surface. You can see them in the ribs, in the scapula, and the pubic rami, and the long bones. So that's what I have for vitamin D deficiency. Let's talk now about vitamin D toxicity. Vitamin D toxicity can be caused either by oversupplementation or else by granulomatous disorders. So granulomatous disorders are characterized by granulomas, which are clusters of macrophages that have undergone transformation to become epithelioid cells. And so those epithelioid macrophages within the granuloma can produce 1-alpha hydroxylase, and it causes autonomous production of calcitriol. So it's unregulated 1-alpha hydroxylase activity in the epithelioid macrophages within the granuloma of the granulomatous disease that is causing this vitamin D toxicity. Something to think about if you have a patient who has no exposure to vitamin D oversupplementation. And so too much vitamin D is going to cause a ton of bone resorption. So you'll see the opposite of the things that we saw with vitamin D deficiency and hypocalcemia. Hypercalcemia, remember the mnemonic, is stones, bones, thrones, groans, and psychiatric overtones. Stones being kidney stones, bones being bone pain. thrones being increased urinary frequency, groans being abdominal pain, maybe nausea, vomiting, and psychiatric overtones like anxiety and depression. In addition to hypercalcemia, you can also see hypercalciuria. So we'll talk quickly about therapeutic uses of vitamin D. A big one that you'll see a lot is this is something that needs to be supplemented in newborns, both breastfed newborns and formula-fed newborns. Along that same vein, you can also supplement vitamin D prenatally in vegetarian mothers. Vitamin D can also be used in treatment of osteoporosis as well as Paget disease. So let's wrap this up. We've been talking about vitamin D, which is a fat-soluble vitamin that functions as a hormone to promote the absorption of calcium and phosphate. And it also enhances bone mineralization. There were two big forms of vitamin D that we could start with, either vitamin D2 from plants or D3, most of which is synthesized in the skin, but some comes from the diet as well. That major source being that activation of vitamin D3 in the stratum basale of the skin. Vitamin D is hydroxylated one time to calcidiol and then again to calcitriol, which is the active form, and that's what goes out to the tissues and performs these functions. The most important enzyme being that 1-alpha hydroxylase enzyme that turns the calcidiol into the active calcitriol. Once that calcitriol is done performing its functions, we can break it down into calcitroic acid and excrete it in the bile. Vitamin D deficiency causes either rickets or osteomalacia. We talked about the very striking bone findings that you can see for both. Vitamin D toxicity, on the other hand, causes hypercalcemia from an increase in bone resorption. Think stones, bones, thrones, groans, and psychiatric overtones. And because vitamin D is good at promoting bone mineralization, we can use it to treat osteoporosis or Paget disease. We also like to supplement it in babies. We're going to keep on moving through our fat-soluble vitamins, so stay tuned. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin K. Vitamin K is also called phytomenadione. It is a fat-soluble vitamin in a substance class called naphthoquinones, and there are two big subtypes of vitamin K. There's K1 and K2. K1 comes from leafy green vegetables, and its primary functions are going to be in clotting and coagulation. We'll talk about that in a little bit. K2 is found in fermented foods, cheese, and meats, and it's also produced by gut bacteria. Remember, in our introduction to vitamins, we talked about how vitamin K could be made in small amounts in the gut. It is specifically being made in that K2 form. And that K2 form of vitamin K has functions in, yes, coagulation, but also it has bone and cardiovascular functions. In general, though, when we're thinking of vitamin K and its functions, we are largely thinking about its clotting and coagulation effects that we'll talk about later on in this video. Vitamin K is stored in the liver because it's a fat-soluble vitamin. It's stored in the body, and it can be excreted in the bile. So like we said, vitamin K across K1 and K2 has different effects in coagulation, in bone, in the cardiovascular system, and in order to perform those functions, it needs to undergo something called the vitamin K cycle. So let's take a look at our diagram. All right, so we're going to start over here with our dietary vitamin K. And the first step of our vitamin K cycle is going to be an activating step via this enzyme here, vitamin K reductase. Vitamin K reductase is going to reduce vitamin K and turn it into this form here called vitamin K hydroquinone. This is our reduced active form of vitamin K, and this vitamin K hydroquinone is going to be a cofactor for this very important enzyme down here called gamma-glutamyl carboxylase. So it is the reduced form of vitamin K, this vitamin K hydroquinone, that has been loaded up with these electrons to help out this gamma-glutamyl carboxylase. And because we're dealing with a carboxylase enzyme here, it is going to carboxylate proteins of interest, turning them into carboxylated proteins in their active form. When we get back to the outline, I'll talk to you about these carboxylated proteins of interest, but this is how vitamin K has all of the effects that it does. By mediating the activity of this gamma-glutamyl carboxylase and by activating all of these proteins, this is how vitamin K has its downstream effects, for example, in the coagulation cascade. So as vitamin K hydroquinone goes and helps out that gamma-glutamyl carboxylase enzyme, leading to the carboxylation and activation of different proteins of interest, we are then left with an oxidized form of vitamin K called vitamin K epoxide. This is our oxidized, inactive form of vitamin K. To complete our vitamin K cycle and get back to the form of vitamin K that we started with, where we can start everything over again, we're going to use this enzyme here, vitamin K epoxide reductase, VKOR, to bring our vitamin K epoxide back to just straight vitamin K, where we can start everything over. over. So let's take it back to the outline, review the vitamin K cycle. The first step was vitamin K turning into vitamin K hydroquinone, which was the reduced active form of vitamin K, and the enzyme that mediated that step was vitamin K reductase. Once we had our vitamin K hydroquinone, that was a cofactor to that important enzyme gamma-glutamyl carboxylase, which goes on and activates proteins, specifically doing so via gamma carboxylation of glutamate residues on those proteins. So that carboxylation is that activation of our proteins of interest. So what are our proteins of interest? Well, the big one, and of these functions, the most likely to be tested, is the gamma carboxylation of coagulation factors, specifically the vitamin K-dependent coagulation factors, which are 2, 7, 9, and 10. Additionally, it will gamma carboxylate proteins C and S, which are part of the anticoagulant system. And the gamma carboxylation of all these things allows for the binding of calcium, and the binding of calcium allows for the interaction of these coagulation factors in the coagulation cascade. So if you haven't learned the coagulation cascade yet, I'm sorry to be the one to break this image to you. All of these are just all the steps that go into making a fibrin mesh, which forms a clot. So down here in this part of the image, you can see how gamma-glutamyl carboxylase and vitamin K feeding into that primes and activates all of these vitamin K-dependent clotting factors, as well as proteins C and S, for their contribution to the cascade here. And I've highlighted just to show you the activated forms of the vitamin K-dependent coagulation factors. We have 2, 7, 9, and 10, all in the A forms, the activated forms. And if you'll notice, the activating step for each of these depends on calcium. Remember, we said it is that gamma carboxylation that allows that calcium to actually bind and interact. You can find more details on the coagulation cascade and all the ins and outs of this wonderful diagram in the hematology section. All right, so those vitamin K-dependent coagulation factors were some examples of the carboxylated proteins that are formed by the activity of gamma-glutamyl carboxylase. Let's talk about some other ones. Another one is osteocalcin, and the function of osteocalcin is to incorporate calcium into bones. You might start to notice a bit of a calcium theme here, and this is how we get our bone functions out of vitamin K. Another one is called matrix G1A protein, or MGP, and this prevents vascular calcification. So it stops calcium from depositing in your blood vessels. Again, the calcium theme here keeps ringing true, and this is how we get our cardiovascular functions out of vitamin K. Far and away, though, the coagulation factors are the highest yield of these functions. And through that reaction with that activity of that gamma-glutamyl carboxylase, we turned that vitamin K hydroquinone into vitamin K epoxide. That was the oxidized and inactive form. To get back to the start of the vitamin K cycle, we used vitamin K epoxide reductase, or VCOR, to turn vitamin K epoxide back into vitamin K. All right, so let's talk about vitamin K deficiency. Vitamin K deficiency can come from fat malabsorption, liver failure, antibiotic disruption of the microbiome. Like we said, remember, some vitamin K can be made in the gut. Antagonists like warfarin, which is a drug we'll talk about in a minute, and also from neonatal deficiency. There's a couple reasons why neonates are deficient in vitamin K. Number one, the neonatal gut is sterile, so there's no bacteria in there yet to actually make vitamin K. Additionally, vitamin K doesn't really cross the placenta, so they can't be getting it in utero. Breast milk doesn't really contain vitamin K, and the neonatal liver isn't quite good enough at synthesizing the active form of vitamin K. So between all those things, neonates are deficient in vitamin K, and we'll talk about some implications of that in a little bit. Because vitamin K is such a prominent contributor to the coagulation cascade, you can imagine that a vitamin K deficiency could lead to hemorrhage. In addition to large-scale hemorrhage, you might see microhemorrhage, which would present more subtly perhaps as petechiae, like the little pinpoint spots of bleeding, or bruising. And because the vitamin K dependent coagulation factors are 2, 7, 9, and 10, which span across both the intrinsic and the extrinsic coagulation pathway, you're going to see an increase in PTT as well as PT-INR. PTT representing our intrinsic pathway, PT and INR representing our extrinsic pathway. Which, as a little side note, maybe outside the scope of this video, but the way that I remember which aligns with what is you play table tennis indoors, that's TT, and you play tennis, regular tennis, outdoors. So the intrinsic pathway is table tennis that you play indoors, and the extrinsic pathway is tennis, which you play outdoors. All right, so that's a little about vitamin K deficiency. Let's talk now about the other side of the coin, vitamin K toxicity. This is pretty rare to see. I would be surprised if this were tested. When you see vitamin K toxicity, it is usually due to over-supplementation. We supplement vitamin K in neonates for reasons like we discussed up here. If we over-supplement a neonate, however, that could lead to trouble. You can get a hemolytic anemia, which can lead to a hyperbilirubinemia and jaundice, right? That bilirubin coming from the lysis of the red blood cells. That bilirubin can cross the blood-brain barrier and lead to kernicterus in infants, which is severe neurotoxicity from that bilirubin in the brain. So that brings us to the therapeutic uses of vitamin K. And like we said, vitamin K deficiency leads to bleeding. So to prevent a vitamin K deficiency bleeding in infants, we give prophylaxis with a vitamin K injection at birth. Now let's say a baby doesn't get their vitamin K injection as bleeding prophylaxis and they develop a hemorrhage. The way that you treat vitamin K deficiency bleeding is with vitamin K replacement plus or minus a transfusion. And specifically the transfusion would be of fresh frozen plasma. This is something that they could very easily test. If they set up the whole clinical picture for you, you have a neonate and the parents refused all preventative treatments in the well baby nursery, and then this newborn develops a hemorrhage, you should suspect a vitamin K deficiency bleeding. What you'll do at that point is you'll give vitamin K, and then, depending on the hemodynamic status, you would consider this transfusion. We specifically use fresh frozen plasma because that is what contains the vitamin K dependent coagulation factors, so that 2, 7, 9, and 10. The NBME likes to test if you know the difference between your different transfusion agents. So the difference between FFP and something like cryoprecipitate, which does not contain 2, 7, 9, and 10. So if you're going to choose to transfuse, make sure you are selecting the right agent that will actually replace those coagulation factors that are deficient. All right, that's enough about vitamin K deficiency bleeding and prophylaxis. Let's talk now about vitamin K antagonists. The famous drug that you must know is warfarin. The way that warfarin works is it inhibits the vitamin K epoxide reductase, that VCOR, specifically the C1 subunit. By inhibiting that VCOR C1 subunit, we will decrease the formation of active vitamin K. Right, if we zoom in, if we're blocking everything off here, we're trapping all of our vitamin K in this inactive vitamin K epoxide form. And we're not forming our active constituents downstream, which means we're not going to have functioning of this gamma-glutamyl carboxylase. So without that vitamin K hydroquinone to activate that gamma-glutamyl carboxylase, we're going to have decreased gamma carboxylation of those coagulation factors. And that leads to anticoagulation in the body. And sure enough, that is the purpose of warfarin. It is an anticoagulant. It's kind of an old school drug. You don't see it so much in practice, but it is tested all the time. So you would use something like warfarin, for example, in the case of AFib, where your heart's doing a bunch of small little fluttering beats that aren't really moving the blood forward, and that stasis is procoagulant. So you would prescribe something like warfarin to stop the formation of clots. Very important to know about warfarin is it has a very narrow therapeutic window, so you monitor the PT-INR. You want to make sure you're not overdoing it and leading to hemorrhage or something that would look akin to a vitamin K deficiency. You're measuring your PT-INR because remember, PT-INR, that PT, that's the extrinsic pathway, which includes factor 7, and factor 7 out of the coagulation factors has the shortest half-life. So that's going to be the one to tank down first, which is why you're monitoring specifically the PT-INR. Because factor 7 has the shortest half-life, it is the most sensitive to changes like that, and you can pick it up the earliest. The other thing to know about warfarin is if you overconsume vitamin K, if you're eating too many of those leafy greens, you can get subtherapeutic warfarin. If you put more vitamin K into your body than the warfarin can block, then the warfarin's not going to be able to tackle all that extra vitamin K, and you'll be subtherapeutic. An INR of 2 to 3 is usually your sweet spot for anticoagulation. Sometimes you can see it a little higher in certain contexts, but this is usually what you're kind of looking for. Anything lower than that is subtherapeutic, and anything too much higher than that is going to be supratherapeutic. All right, so let's wrap this up. We've been talking about vitamin K, also called phytomenadione. This is our fat-soluble vitamin, and it had functions primarily in clotting, but also in the bone and had cardiovascular functions. Remember, calcium and calcium incorporation was kind of a big theme with vitamin K, either by allowing it to bind in those vitamin K-dependent coagulation factors, which were 2, 7, 9, and 10, by helping incorporate calcium into bones, or by preventing vascular calcification. The way that it performed all of these functions was by its participation in the vitamin K cycle. Vitamin K was activated to that active form, that vitamin K hydroquinone, which could act as a cofactor to that gamma-glutamyl carboxylase. And that was what was in charge of activating all all those proteins via the gamma carboxylation of glutamate residues on proteins of interest. That vitamin K hydroquinone, in the process of participating in that carboxylation, was oxidized into an inactive form called vitamin K epoxide via the enzyme vitamin K epoxide reductase, which was very important when we discussed warfarin and the mechanism of action of that famous anticoagulant. We talked about how vitamin K deficiency causes hemorrhage and how vitamin K toxicity is rare but can be seen in oversupplementation. One population that we do supplement vitamin K in is neonates to prevent vitamin K deficiency bleeding. Let's keep on moving through our fat-soluble vitamins. Till then, that's all I got for you. Good job, good luck, and keep practicing.
Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin E. Vitamin E is the last fat-soluble vitamin we're going to be talking about in this unit. And it is from a class of molecules called tocopherols, which is just a fancy word for a methylated phenol. Vitamin E comes from your diet, specifically from sources like meat, eggs, leafy vegetables, and vegetable oils. Because it's a fat-soluble vitamin, similar to the other fat-soluble vitamins, it will be stored in the adipose or in the liver parenchyma. The primary functions of vitamin E are as an antioxidant, but it also has inhibitory functions in cell aggregation and proliferation and adhesion, as well as functions in gene modulation. We'll start off our discussion by talking about those primary antioxidant properties. So let's zoom into our diagram. All right, so here is our diagram. And vitamin E, which is sort of the star of our show, doesn't come in until down here. So a lot of this up here is set up for the function of vitamin E. We're actually going to start up here with the electron transport chain. From our electron transport chain, we made oxygen-free radicals. Now that oxygen-free radical is going to turn into a hydroxyl-free radical, an OH-free radical, by means of a bunch of steps, the details of which are not important for our discussion right now. So we've set ourselves up with this hydroxyl-free radical that has an unpaired electron. And that hydroxyl-free radical with its unpaired electron is going to meet a polyunsaturated fatty acid, or a PUFA, P-U-F-A. All that a polyunsaturated fatty acid is, if you think back to our introduction to lipids and the terminology about lipids, it's a fatty acid with more than one double bond here. Those double bonds are unsaturated because they're not making the maximum number of different pairs that they could be making. We could have anything here as our R1 and R2 groups. It doesn't really matter what the polyunsaturated fatty acid is. You don't have to memorize any of these structures. They're just drawn out here because it helps me to teach it to you, and I think sometimes it can be helpful to actually visualize what's going on. So we have our polyunsaturated fatty acid of whatever identity meeting up with our hydroxyl radical with unpaired electrons. And that free radical is going to transfer onto the polyunsaturated fatty acid and turn it into a polyunsaturated fatty acid radical, a PUFA radical. And I'll erase my drawing off the diagram so you can see from this point forward, we can follow that free radical down this pathway. This free radical, as we'll follow it down, is trouble. And so it's vitamin E's job to handle and neutralize that free radical. That's why we're having this discussion. All right, so now we have our PUFA radical, and through a series of other steps, again, I'm not going to bog you down with this, we're going to end up with a PUFA paraxyl radical. So we added on this paraxyl group right here, and you can see our free radical is still attached, it's just in a different spot. Now, this PUFA paraxyl radical is trouble because it will start to create a vicious self-propagation cycle. What I mean by that is when a PUFA paraxyl radical encounters another PUFA, another polyunsaturated fatty acid, just like that we started with up here, it can transfer that free radical onto the polyunsaturated fatty acid and form another PUFA radical, which can go back and form another paraxyl radical, and so it can keep running this loop and activating more and more polyunsaturated fatty acids into that radical form. That process of the PUFA paraxyl radical meeting and free radicalizing is called self-propagation of lipid radicals. That's what we're referring to. Okay, so we've established this whole nasty cycle of free radicals that are then free to go and wreak havoc in your body. So we got to find a way to stop this PUFA paraxyl radical, and that is where vitamin E comes in. Vitamin E, remember also called tocopherol, will sacrifice itself and it will take on the burden of that free radical, and it will form a tocopherol radical. So we've transferred our free radical now onto vitamin E. I'm going to finish up talking about the pathway of the polyunsaturated fatty acids, and then we'll come back to how does vitamin E actually deal with this. Once that PUFA paraxyl radical has gotten rid of the free radical, it just becomes PUFA peroxide, which is just a type of peroxide, and that peroxide can be acted upon by this enzyme glutathione peroxidase, which will use the help of reduced glutathione, turning it into oxidized glutathione, and then our PUFA peroxide will turn into a PUFA alcohol, and that is harmless, that is neutralized, and it is out of the way of this nasty self-propagation cycle. If this glutathione peroxidase thing is looking familiar to you, it should be. We've talked about this before. Specifically, we talked about it when we spoke about the oxidative burst. If you remember this step 4 right here, mediated by glutathione peroxidase, we started with hydrogen peroxide, just another type of peroxide, like our PUFA peroxide. And glutathione peroxidase took reduced glutathione and our peroxide and turned it into the alcohol form. In this case, the alcohol form of hydrogen peroxide is just water. And that reduced glutathione turned into oxidized glutathione that had to be replenished by NADPH. And we talked all about that in the video on the oxidative burst. Go check that out if you need a refresher on how we do all that replenishing of glutathione. All right, so thanks to the help of vitamin E, we turned our PUFA peroxyl radical into PUFA peroxide, which was a form that could be acted upon and turned into the alcohol form via this glutathione peroxidase. So what actually happens to this vitamin E that has so nobly sacrificed itself and taken on the burden of that radical? Well, I've given a lot of credit to vitamin E for taking on this radical burden, but it couldn't do it without the help of its partner, vitamin C, which we'll talk about in the next video too. Vitamin C, or ascorbate, can take that radical and become dehydroascorbate, and that'll turn the tocopherol radical back into the plain vitamin E tocopherol form, ready to neutralize another PUFA peroxyl radical. And then there's a bunch of replenishing steps. So now we have to replenish vitamin C, right? We've made all this dehydroascorbate. So we'll use our friend reduced glutathione to the rescue again to replenish our vitamin C from the dehydroascorbate form. We'll be left with oxidized glutathione in the meantime. And we replenish that reduced glutathione via glutathione reductase, requiring NADPH and NADP+, just in the same way we saw when we talked about the oxidative burst. Enzyme 5 over here was glutathione reductase, which replenished reduced glutathione from oxidized glutathione, requiring NADPH that came from the pentose phosphate pathway. I told you guys this chapter would be a walk down memory lane of all of the pathways that we have grown to know and love throughout the biochemistry unit. So back to the outline, remember the electron transport chain was causing a lot of oxygen-free radicals, and those were turning into hydroxyl-free radicals. When that hydroxyl radical met up with a polyunsaturated fatty acid, or a PUFA, it would form the radical form of that PUFA, a PUFA radical. And through a couple more steps down the line, that PUFA radical could turn into a PUFA peroxide radical. We talked about how that PUFA peroxide radical could actually self-propagate and activate other PUFAs into their radical form. So to the rescue came vitamin E, or tocopherol, which would take the radical from the PUFA radical and leave us with a PUFA peroxide, as well as a tocopherol radical now. And by turning that PUFA peroxyl radical into just the peroxide, we could decrease lipid radical self-propagation. We could take that PUFA peroxide and turn it into the alcohol form of that polyunsaturated fatty acid with the help of reduced glutathione. And then what was the fate of our tocopherol radical, or the radical form of our vitamin E? Well, with the help of vitamin C, we could replenish that vitamin E. Vitamin C could take that radical and form dehydroascorbate. And then how do we replenish our vitamin C now? Well, from the help of reduced glutathione, we can have a reaction between the reduced glutathione and the dehydroascorbate, replenish our vitamin C, and that leaves us with oxidized glutathione. And we replenish the reduced glutathione from the oxidized glutathione with the help of NADPH via glutathione reductase. All right, so that was a lot about the antioxidant side of vitamin E. Let's talk quickly about some of the other functions of vitamin E. Vitamin E decreases platelet aggregation, cell proliferation, and monocyte adhesion. It does this by decreasing the efficacy of phospholipase A2. So without getting too into this, it's a little outside the scope of this video. Phospholipase A2 mediates the release of arachidonic acid, which is pro-inflammatory. The antioxidant effects of vitamin E will reduce the number of substrates available for phospholipase A2 to work. In a similar vein, we'll also see decreased protein kinase C activity from the IP3 DAD pathway. Again, the specifics of those pathways outside the scope of this video, you have enough on your plate for now. Just something to be mindful of as you're going back through trying to synthesize everything for your exam. And another function of vitamin E is it can decrease gene transcription. For example, the transcription of the genes for the tocopherol transport protein as well as some components of tropomyosin, which remember was a regulator of muscle contractility. So let's switch gears and let's talk about a vitamin E deficiency. Vitamin E deficiency, usually pretty rare. It can happen from fat malabsorption generally, as is the case with most of our fat-soluble vitamins. And for clinical presentation for a vitamin E deficiency, you might see a hemolytic anemia with acanthocytosis due to damage from reactive oxygen species, right? We don't have vitamin E to go fight all those free radicals in the body. Here are pictures of acanthocytes. You can see they have these spiky projections from their membrane sticking off here. That's from that free radical damage. Now, vitamin E deficiency is not the only condition where you can see these acanthocytes. I believe we first introduced these when we talked about A-beta lipoproteinemia, when we talked about cholesterol metabolism, but you can also see this in liver disease or in patients who have had a splenectomy, where the spleen isn't there to take out these defective, funky red blood cells. Now, a very tricky presentation of vitamin E deficiency is neurologic damage, and the reason that it's tricky is because it looks just like a B12 deficiency. We're putting the cart before the horse a little bit because we haven't quite talked about what a B12 deficiency looks like. So take my word for it and put a pin in it if you're not familiar with what B12 deficiency looks like. We'll circle back to that, but in a vitamin E deficiency, just like in a B12 deficiency, you're going to see demyelination of the posterior column and the spinocerebellar tract, and this leads to decreased proprioception, vibration, and balance, all of which leads to ataxia. And so clinically, these are next to impossible to distinguish. However, in a vitamin E deficiency, you're not going to see a megaloblastic anemia, and you're going to have a normal methylmalonic acid. That's in contrast to a B12 deficiency, where you might see a megaloblastic anemia and you might see an elevated methylmalonic acid. A good point to come in and clarify here is the point about the anemias. So a vitamin E deficiency and B12 deficiency can both present with anemia. The anemia of a vitamin E deficiency is hemolytic. This means that the red blood cells are being destroyed. And a hemolytic anemia is normocytic, with a normal mean corpuscular volume, right? The actual volume of the red blood cells is going to be fine. There's nothing wrong with the way that these red blood cells are being made. The problem is that they're being destroyed by the reactive oxygen species. The anemia of a vitamin B12 deficiency is usually, classically on the test, a megaloblastic anemia, where the mean corpuscular volume is elevated. That's because the problem in a B12 deficiency, like we'll talk about, is a problem with DNA synthesis. So those red blood cells look a little different under the microscope. Now, the presence of a normocytic anemia doesn't necessarily rule out a B12 deficiency, because sometimes in early stages of B12 deficiency, that MCV can be normal, or those cells can still be normocytic. But the hemolytic anemia that you see in vitamin E deficiency will never be megaloblastic. So when you see a megaloblastic anemia, which is a macrocytic anemia with an elevated MCV, mean corpuscular volume, you should be thinking more of B12 than vitamin E deficiency. So in my mind, there are sort of two ways they can test this. They can make you differentiate between a B12 deficiency and a vitamin E deficiency, and they could give you lab values. If they were to give you lab values, I don't think they would be able to make you select a vitamin E deficiency based on the absence of these findings, because these things could be absent in a B12 deficiency. So if they were to make you differentiate between a vitamin E and a vitamin B12 deficiency, where both of those were answer choices, they would probably be forced to give you slam dunk labs where they showed you a megaloblastic anemia and an elevated methylmalonic acid to point you towards B12 and away from vitamin E deficiency. I don't necessarily think they could test it the other way around, though. What they could do, though, is with these vitamin questions, they love to make it clinical presentation based and not give you any labs at all. They could just give you this clinical presentation with the decreased proprioception, balance, and vibration leading to ataxia. Most people, or at least for me, when I read those things, I'm not immediately thinking about a vitamin E deficiency. When they're testing that, I'm usually thinking of a B12 deficiency. But if you get to the end of a stem that's describing this, and B12 is not an answer choice that they give you to pick, think about and immediately look for vitamin E deficiency. It is a classic mimic. Other things that are going to help you tell these things apart are going to be the clinical context. If somebody has a fat malabsorption syndrome or pancreatic insufficiency, steatorrhea, what have you, you're more thinking of a vitamin E deficiency. On the flip side of the coin, let's talk about vitamin E toxicity with too much vitamin E. This is rare too. It's going to usually come from oversupplementation, and the risks associated with this are an increased risk of necrotizing enterocolitis in infants and an increased bleeding risk, as well as supertherapeutic warfarin, which you can kind of remember if you remember that vitamin E does decrease your platelet aggregation. Some quick therapeutic uses of vitamin E: we can use it as part of the therapeutic management of non-alcoholic steatohepatitis, and vitamin E oils and things can also provide some protection of the skin barrier. So let's wrap this up. We've been talking about vitamin E, the last of our fat-soluble vitamins that we'll be talking about, and vitamin E's main claim to fame was as an antioxidant. We set up the stage talking about the dangers of self-propagating lipid radicals, and vitamin E's job was to sacrifice itself and take the burden of the radical away from the polyunsaturated fatty acid. Vitamin E was equipped to handle that because of its partner vitamin C, that could help replenish it. We had several more replenishing steps that included our old friend reduced glutathione. We talked about vitamin E deficiency, how you can see this in fat malabsorption, and how it can present with a hemolytic anemia with acanthocytosis, those spiky red blood cells from the reactive oxygen species damage when vitamin E is not there to take those reactive oxygen species away. We talked about how vitamin E deficiency can look a lot like a vitamin B12 deficiency. We talked a little bit about toxicity and therapeutic uses as well. That's it for the fat-soluble vitamins. We're going to mark our introduction into the water-soluble vitamins by talking about vitamin E's partner in crime, vitamin C. So stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing.
Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin C. We are shifting gears into our discussion on water-soluble vitamins. So vitamin C is the first water-soluble vitamin we're going to talk about in this chapter, and it's in a substance class or class of molecules called lactones. And vitamin C, as you may be familiar with, comes from fruits and vegetables. When you eat these fruits and vegetables, the vitamin C can be absorbed actively in the jejunum or passively via the oral mucosa. So it can be absorbed in either of those ways and then excreted by the kidneys as vitamin C or a vitamin C metabolite like oxalate. And vitamin C has multiple functions like participating in antioxidant and redox reactions, which we got a little bit of a sneak preview to in the last video on vitamin E. It also has functions in iron absorption and as a coenzyme for synthetic enzymes like collagen. So let's jump into it by talking about some of the functions of vitamin C. So we got our introduction to vitamin C in the last video we did on vitamin E, when we talked about this whole antioxidant pathway over here, and we said that vitamin C is sort of the sidekick to vitamin E. Specifically, vitamin C helped regenerate vitamin E, which reduces the propagation of lipid radicals. So just as kind of a refresher, remember we had all of these free radicals coming from the electron transport chain, and those free radicals were getting added onto polyunsaturated fatty acids, or PUFAs, and those were forming these PUFA radicals, which came in lots of different forms. And those free radicals are destructive, and so those radicalized polyunsaturated fatty acids, or those PUFA radicals, downstream could turn into PUFA peroxyl radicals, and those were problematic because those could further go on and create this propagation loop, continuing to add radicals onto polyunsaturated fatty acids and creating more and more of these radicalized lipids. So in our last video on vitamin E, we sort of made vitamin E the hero that would take on the burden of that free radical. And so we would take the radical off of our PUFA peroxyl radical and turn it into a radicalized form of vitamin E, this tocopherol radical. But in order to regenerate that vitamin E for its future participation in these reactions, we had to find a way to get the radical off of the vitamin E and turn that tocopherol radical back into vitamin E. And that was where vitamin C came in. The other name for vitamin C is ascorbate. And so that tocopherol radical plus that ascorbate is going to give you out back your original vitamin E and then form something called dehydroascorbate up here. To regenerate that vitamin C from dehydroascorbate, we used reduced glutathione, which gave us back our vitamin C as well as the oxidized form of glutathione. And then we regenerated that reduced glutathione by taking our oxidized glutathione and having it undergo a reduction reaction with NADPH. And the enzyme that mediated that was glutathione reductase. If you didn't watch the video on vitamin E and that was too quick for you, go ahead and backtrack, it'll make a lot more sense. So ascorbate, or vitamin C, plus the tocopherol radical left us with dehydroascorbate and tocopherol, or plain vitamin E. And we reformed our vitamin C or ascorbate with the help of reduced glutathione. Something interesting about the antioxidant properties of vitamin C is that it can cause a false negative stool guaiac test. So a stool guaiac test is a type of fecal occult blood test. It's looking for blood in the stool. And the way you perform the test is you'll do a digital rectal exam, you'll get a small stool sample, and you'll put it on a test card, and that test card contains a reagent called guaiac. From there, you'll go ahead and apply another reagent, which is hydrogen peroxide. And so if there's blood in the stool, then the heme will catalyze the oxidation of the guaiac on the test card by the hydrogen peroxide, and you'll get this colorimetric reaction that turns the card blue. The thing about vitamin C is that its antioxidant properties can interfere with this redox reaction that's going on with the peroxide and lead to a false negative test. So just one thing to keep an eye out for. And there are lots of things that cause false negative, false positive results in a stool guaiac test, which is why they're typically not used as confirmatory tests. All right, so that's enough about the antioxidant functions of vitamin C. Let's talk now about some of the other functions. One other function of vitamin C is its role in iron absorption. Vitamin C will act as a chelating agent, which will promote the solubility of iron, as well as reduce the Fe3+ form, or the ferric form of iron, to the Fe2+ form, or the ferrous form of iron. And if you ever forget the difference between ferric and ferrous, I remember in the word ferrous, it ends in OUS, and so the rhyme I remember is OUS is less. So that's the 2+ form. But at any rate, by favoring the ferrous form of iron, we're going to promote intestinal absorption of iron. So that's another perk of eating your fruits and vegetables. And finally, vitamin C is a cofactor for various synthetic enzymes. Vitamin C helps mediate proline and lysine hydroxylation in the collagen synthesis pathway, which we learned about a long time ago, but is coming back now. So here's our collagen synthesis pathway that we learned about to kick off our whole chapter on collagen and connective tissue. I told you this chapter was going to be a walk down memory lane. I'll spare you the full recap, but remember, one of the first steps was taking pre-pro collagen and hydroxylating it, so adding these OH groups on to the lysine and proline residues. And then after that hydroxylation, there was the glycosylation, where we added sugar to the hydroxylysine, and that created a marker for exocytosis. So after we put together 3 of these strands to form this triple helix procollagen, we could send it out of the fibroblast. None of that would be possible without that hydroxylation step that requires vitamin C. Another place where you've seen the synthetic enzyme cofactor functions of vitamin C before is in norepinephrine synthesis, where it was a cofactor for dopamine beta hydroxylase, which turns dopamine into norepinephrine. Just to remind you that you have seen this before, not too long ago, this was our big map of phenylalanine metabolism. We're going to zoom in on enzyme 5 over here, which is our dopamine beta hydroxylase, which turns dopamine into norepinephrine, and sure enough, you can see vitamin C was the cofactor. And some other biochemistry functions that we haven't necessarily shown on a diagram. Vitamin C is involved in the synthesis of carnitine, as well as peptide hormone synthesis from pre-hormones. So for example, ADH, oxytocin, and calcitonin. All of those synthesized from pre-hormones with the help of vitamin C. So let's talk about vitamin C deficiency, also known as scurvy. We talked about this a little bit when we talked about collagen synthesis as well. Low dietary vitamin C leads to scurvy. Famously, pirates who were out on the open seas with no access to fruits and vegetables for a long time would classically get this, but anybody with poor nutrition today could get it as well. Low vitamin C means low collagen synthesis, right? We're missing that hydroxylation step. So without the collagen, we're going to end up with a lot of problems with connective tissues in our body. So you'll get corkscrew hair, perifollicular hemorrhage, so bleeding around your actual hair follicles, follicular hyperkeratosis, and poor wound healing. All of these are especially high yield to know. I'll show you this image over here, which they love. Remember, this vitamins chapter is one where they really like clinical presentations. They're not going to be loading you up with labs and things. They're just going to give you somebody who's sick and tell you to figure it out. And with that question type comes a lot of pictures. So here you can see some of the perifollicular hemorrhage, right? Those little bleeding spots around the hair follicles. You can also see these corkscrew hairs where they're really coiled up tight in the shape of a corkscrew.
And you might be able to make out some perifollicular hyperkeratosis as well. Just those little spots there that are those keratin mounds. Now, also because of that defective and decreased collagen synthesis, you're going to have very weak blood vessels. The strength of the walls of those blood vessels relies on strong, healthy connective tissue. So you can see a fair amount of bleeding with a vitamin C deficiency, either petechiae or mucosal bleeding, bruising, gingivitis, and then you can also see subperiosteal hemorrhage, so bleeding under the periosteum of the bones. And that can lead to something called a sorbutic rosary. Now, the sorbutic rosary can be tricky. So if you remember when we talked about rickets in the vitamin D deficiency video, we talked about the ricketic rosary. That was this distension of the bone cartilage junction. Classically, when they tested the costochondral junction between the ribs and the cartilage. And we showed the X-ray finding of this too. So that was the ricketic rosary. The sorbutic rosary can look very similar. You can see a distension like that, but it's from hemorrhage underneath the periosteum, and that is going to be tender. So the ricketic rosary with vitamin D is non-tender because it's not due to bleeding. The sorbutic rosary will be tender. Additionally, a ricketic rosary is a little knobbier than a sorbutic rosary, which can be a little more angular. Here's a picture of the gingivitis associated with vitamin C. This is another image that they do really like to test, this gingivitis. And then the other thing we can see in scurvy or vitamin C deficiency is anemia. We can either see an iron deficiency anemia that is caused by vitamin C deficiency because of vitamin C's role in iron absorption, or we can see a folate deficiency, and this is not really caused by the scurvy. It's just that both are comorbid with malnutrition, and so you'll often see them together. Now let's talk about the opposite, vitamin C toxicity. It's pretty hard to get a toxicity of a water-soluble vitamin outside of the case of oversupplementation. So in general, when you see water-soluble vitamin toxicity, you should be thinking of oversupplementation, and in the case of vitamin C, this can lead to nausea, vomiting, diarrhea, as well as an increased risk of iron toxicity in people who are predisposed. Again, because vitamin C is involved in iron absorption. People who are predisposed to iron overload are people with hemochromatosis, as well as people who are chronically receiving blood transfusions. Both of those demographics are high risk. Otherwise, you're not super likely to see iron overload in somebody who has no underlying problems with iron. The other thing about a vitamin C oversupplementation is you can see an increased risk of calcium oxalate nephrolithiasis, or calcium oxalate kidney stones. Remember, we said that oxalate was a metabolite of vitamin C. Again, we're really only seeing this in the cases of oversupplementation, like taking vitamin C supplements. If you're eating a ton of fruits and vegetables, that's not going to cause toxicity, and that's especially not going to cause calcium oxalate nephrolithiasis, because fruits and vegetables also contain protective factors against kidney stones like citrate. It's just when you take the vitamin C out of that fruit form that has all those other good things like the citrate in it that you start to lead to trouble. Finally, therapeutic uses of vitamin C, other than that it's a good part of any balanced diet, is it is a second-line treatment for methemoglobinemia. Remember, methemoglobinemia is a condition where the iron in hemoglobin is in the 3+ form, and that's not as good at binding oxygen. Remember, vitamin C can reduce the ferric to the ferrous form of iron. And so it's a reasonable treatment for methemoglobinemia. It's not the first-line treatment. The first-line treatment is methylene blue. But this is something to be aware about as well, because it could, in theory, test if you know all of the functions of vitamin C. So let's wrap this up. We've been talking about vitamin C, which is the first water-soluble vitamin of this chapter. We've been talking about its many functions, including as an antioxidant, playing alongside vitamin E in the fight against polyunsaturated fatty acid radicals. It was also involved in iron absorption and was a cofactor for various synthetic enzymes, including its involvement in collagen synthesis, norepinephrine synthesis, and some other synthetic pathways. We revisited the topic of scurvy or vitamin C deficiency, which leads to decreased collagen synthesis. And that led to a variety of bleeding, bruising, and connective tissue complications. We talked a little bit about toxicity, which mainly comes from oversupplementation, and its therapeutic use as a second-line treatment for methemoglobinemia. Let's keep on moving through our water-soluble vitamins. We have a list a mile long of B vitamins to cover up next, so stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing.
Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin B1. Vitamin B1, also known as thiamine, is the next water-soluble vitamin we'll be talking about. Now in order to activate thiamine, we will phosphorylate it into the form thiamine pyrophosphate. And there's no real need to delve into that process at all, just a fact for you. And thiamine is going to be fortified in processed grains like bread and cereal. So those are going to be your main dietary sources. Let's jump into some of the functions of vitamin B1. Vitamin B1 is a heavy hitter in your body. This is a major metabolic enzyme cofactor. Like I said, this vitamins chapter is going to be a walk through memory lane where we go back and revisit a lot of the biochemistry pathways that we've talked about so far in this unit. So let's go ahead and revisit some of those major pathways that contained thiamine. The first one being the pyruvate dehydrogenase complex, which turns pyruvate into acetyl-CoA. We can take a look at our diagram that showed us the fates of pyruvate. We can check out pyruvate dehydrogenase, which was enzyme C over here, which turned pyruvate into acetyl-CoA so it could go on and participate in the TCA cycle. And remember, the cofactors for that pyruvate dehydrogenase complex, or that massive enzymatic complex, were B1, B2, B3, B5, and lipoic acid. And so sure enough, there is our appearance by thiamine. So here's our TCA cycle, and the alpha-ketoglutarate dehydrogenase complex was enzyme C here, which turned alpha-ketoglutarate into succinyl-CoA. And that also required vitamin B1 as a cofactor. So in the process of aerobic respiration, we've already used vitamin B1 twice just to get pyruvate down to and then through the TCA cycle. So it's a major player in aerobic respiration, and that'll come into play down the line when we talk about thiamine deficiency. Another important enzyme that requires vitamin B1 as a cofactor is transketolase, which turns ribose 5-phosphate to and from glyceraldehyde 3-phosphate. So here we're talking about the pentose phosphate pathway. And we can see this was our diagram that looked at glycolysis, and then also this side pathway here of the HMP shunt, or the pentose phosphate pathway. Remember, two words for the same pathway that produces NADPH off of glycolysis intermediates. Transketolase was part of this last step here that turns ribose 5-phosphate to and from fructose 6-phosphate and glyceraldehyde 3-phosphate. The implication of this reversible enzyme being either that we could turn ribose 5-phosphate back into glycolysis intermediates, or we could take these glycolysis intermediates and use them as part of nucleotide synthesis, which was also sort of attached to both of these pathways. So another big job for thiamine. And then finally, the last big important enzyme that we'll talk about that requires vitamin B1 is the branched chain ketoacid dehydrogenase complex, or the BCKDC. We talked about this when we talked about the metabolism of branched chain amino acids and maple syrup urine disease. The BCKDC turned alpha keto acids into branched chain acyl-CoAs. So here's our metabolic pathway of these branched chain amino acids. We had valine, isoleucine, and leucine that were eventually metabolized into their respective alpha keto acid forms. Those alpha keto acid forms were then metabolized again into their branched chain acyl-CoA forms via this enzymatic complex here, the branched chain ketoacid dehydrogenase complex, requiring vitamin B1 as a cofactor. And those branched chain acyl-CoAs could go down and play in all of these different metabolic pathways. So let's talk now about vitamin B1 deficiency. Some of these concepts should be familiar to you, as I believe we've talked about them earlier on in the biochem unit. A decrease in vitamin B1, which can come from alcohol, malnutrition, malabsorption, bariatric surgery, as well as pregnancy, all of those conditions predispose you to a B1 deficiency, will cause a decrease in TCA cycle activity. Remember, I just finished showing you how important vitamin B1 is to the TCA cycle. We need it to turn pyruvate into acetyl-CoA to even start the cycle, and then we need it as part of the alpha-ketoglutarate dehydrogenase complex. Reduced TCA cycle activity, which is the center of aerobic respiration, means we're going to have decreased ATP and ATP synthesis in aerobic tissues. The big tissues that require a lot of oxygen are the brain and the heart. So in a vitamin B1 deficiency, we're going to have brain findings and/or heart findings. Let's talk about the first brain finding. Of the ways that they can test a thiamine deficiency, I would consider this by far to be the most high yield. And this is Wernicke encephalopathy. We've talked about this before. Now, I'm not supposed to guarantee that things are going to show up on your exam, but if you ask me to put money on one topic to show up on your exam, this would be a contender. They love to test the triad, the clinical features of Wernicke encephalopathy. And that triad is confusion, ophthalmoplegia, and ataxia. This is acute and it is reversible. In a STEM, they're not going to go out and give you those three things right in a row. I feel like the way that I have most commonly seen this tested is a patient will come in with a chief complaint of altered mental status. They'll give you some sort of clue as to why they might be thiamine deficient. They might make it something obvious like alcohol, or they might make it something tough like a pregnant woman with hyperemesis gravidarum who's throwing up all the time. Either way, there's likely to be some sort of risk factor for a thiamine deficiency given to you in the stem. And then they'll take these findings and they'll bury them in a paragraph full of physical exam findings. So they might be alert and oriented only to self, and they probably won't just come out and say ophthalmoplegia, because they're smart, they're on Anki, they know that you know that buzzword, but they'll give you instead a finding like nystagmus. And then they might describe the patient's gait as wide-based or staggering. That's the ataxia component. So it's very important to know this triad, but more than that, it's important to know the different actual clinical manifestations of this triad. All right, so that was Wernicke encephalopathy. Like we said, that is the acute and reversible manifestation of a thiamine deficiency. When this gets to be chronic, though, that's when we're going to get Korsakoff syndrome. Korsakoff syndrome is characterized by amnesia, both retrograde and anterograde. So both trouble with recalling memories from the past and making new memories for the future, as well as confabulation. Confabulation is a really striking clinical exam finding if you haven't seen it before. You'll never forget it when you see it. These are patients who seem like they're making things up to answer your question. So they have distorted, misinterpreted memories. They're not actually trying to lie to you. Instead, their brain is making up these memories to fill in these gaps. The first patient I ever had with this, when he was asked what brought him to the emergency room, he said he was there for a checkup for a rash that he had. He said he had had an appointment for a long time and he just drove into his checkup, despite the fact that he had been brought in as an emergency by ambulance. And like we said, once it gets to this point, this is usually irreversible. The way to remember the clinical findings of Wernicke encephalopathy and then Korsakoff syndrome is with the mnemonic coat rack. So confusion, ophthalmoplegia, and ataxia are from a thiamine deficiency, and this is the Wernicke encephalopathy component. And then retrograde and anterograde amnesia, as well as confabulation, are for Korsakoff syndrome. I know the Wernicke part isn't in the mnemonic, so it's not perfect, but you get the idea. Imaging findings that you can see with this is hyperintensity of the mammillary bodies, either on T2 or T1 with contrast, as well as hyperintensity of the dorsomedial thalamic nucleus. I would say they're more likely to show you a T2, but either's fair game depending on the images they come up with. Here on the left, you can see a T1 with gadolinium contrast. We have both our coronal and our axial views, and you can see the mammillary bodies here are lighting up in a patient with Wernicke encephalopathy. And then over here is a T2 of a different patient. And if you haven't seen any of my older videos over on the anatomy side of boot camp where I talk you through brain imaging, now might be a good time. But right around here, we have the internal capsule. Here is the head of caudate. Here is the lenticular nucleus, which is the globus pallidus and the putamen. And then back over here, we have the thalamus. And you can see here on the contralateral side, this hyperintensity of the dorsomedial thalamus. All right, so that was Wernicke encephalopathy. There's another family of problems that can arise in a thiamine deficiency, and those are called beriberi. And there's three classifications of beriberi. There's dry, wet, and infantile, or mixed. And they're classified based on the tissues that they affect. Like we said, thiamine deficiency really tends to target the brain and the heart. So dry beriberi is going to have nervous system manifestations. Things like symmetrical peripheral neuropathy and muscle wasting that eventually lead to paralysis, as well as Wernicke encephalopathy. On the other hand, wet beriberi affects not the nervous system, but the cardiovascular system. And so you'll see systemic vasodilation leading to high output heart failure, dilated cardiomyopathy, and edema. It's a tough one to remember to keep on your differential for someone with dilated cardiomyopathy and high output heart failure. There's a million things you could be thinking of. But again, if they give you any of these risk factors for a thiamine deficiency, the alarm bells should start to go off. And then there's infantile beriberi, which is a mixed presentation between dry and wet. So both nervous system and cardiovascular manifestations. So you'll see circulatory failure that leads to cyanosis, as well as meningeal irritation and cerebral edema. Let's talk about the therapeutic uses of thiamine. The first one's in the case of malnutrition or alcohol use disorder. Thiamine is frequently supplemented, and it's frequently supplemented empirically. It's quicker, easier, cheaper to just give somebody thiamine as opposed to testing their thiamine levels and waiting for it to come back. Thiamine's a water-soluble vitamin, vitamins, so it's pretty hard to oversupplement. And so you'll give thiamine as part of what we call the banana bag. You'll see these banana bags are these bright yellow bags of vitamins, basically, that are given to patients who need the supplementation. Now, the key is a lot of patients who may need thiamine supplementation may also be hypoglycemic, right? Patients with alcohol use disorder predisposed to hypoglycemia. But you want to give the thiamine before the glucose, and that's because it decreases the precipitation of Wernicke encephalopathy. Remember, thiamine is an important cofactor of the TCA cycle, meaning you want to make sure that the TCA cycle actually has all of its cofactors and all of its enzymes running smoothly before you actually go and give this patient a load of glucose and try and run the TCA cycle. If you give the glucose first and we don't have thiamine there to support the TCA cycle and its enzymes, you can precipitate Wernicke encephalopathy and make things worse. So always give the thiamine first. And then the other therapeutic use of thiamine is in a condition called Lee syndrome, which is a mitochondrial myopathy, and administration of thiamine is just part of the management. I'd say that's a lower yield point, but the NBME seems to love the mitochondrial myopathies more and more these days, so I was too afraid not to say anything. So there's your tidbit. All right, so let's wrap this up. We've been talking about thiamine, which is a water-soluble vitamin that is fortified in processed grains. It is a major metabolic enzyme cofactor involved in a lot of pathways, but perhaps most importantly for our discussion is its involvement in the TCA cycle. Because of that TCA cycle involvement, when thiamine is deficient, we will get decreased ATP in aerobic tissues that require a lot of aerobic respiration in the TCA cycle, like the brain and the heart. And that can lead to a few clinical presentations, the most high yield of which, in my opinion, is Wernicke encephalopathy and its partner Korsakoff syndrome. And we remembered all of their findings together with the mnemonic coat rack. For Wernicke encephalopathy, it was confusion, ophthalmoplegia, and ataxia, attributed to a thiamine deficiency for T. And once we started seeing retrograde and anterograde amnesia as well as confabulation, that was Korsakoff syndrome. We talked about some imaging findings that we could see, like mammillary body and thalamus hyperintensity. Then we talked about the other family of clinical presentations, including dry beriberi, which affected the nervous system, wet beriberi, which affected the cardiovascular system, or infantile beriberi, which could be mixed. And we said in a patient who is deficient in thiamine, if we need to supplement it, always make sure we are giving the thiamine before we give any sort of glucose to help prop up that TCA cycle and set up your patients for success. We're going to keep on moving through our long list of B vitamins to cover, so stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin B3. Vitamin B3 is also called niacin or nicotinic acid. It's another water-soluble vitamin, and in your diet, it's going to come from places like meats, cereals, and legumes. And vitamin B3 is very important because it is activated into NAD+ and NADP+. Those were our major electron carriers in a variety of metabolic pathways throughout the body, which we'll talk about in a minute. So niacin primarily comes from the diet. However, as we talked about when we talked about the metabolism of tryptophan, there is a way to synthesize niacin in a lower amount. It's a poorly efficient reaction from tryptophan, where tryptophan turned into kynurenine, which turned into niacin. Remember when we talked about tryptophan metabolism, this was our diagram here. Tryptophan turning into kynurenine, and then through a series of other steps requiring B2 and B6 as cofactors, we got niacin. And niacin could be activated into nicotinamide and then down the road into NAD+ and NADP+. So we can either start here with dietary niacin, or we can synthesize niacin from tryptophan upstream. So like we said, niacin very important because it forms NAD+ and NADP+. NAD+ was our electron carrier in catabolic redox reactions, mainly as an oxidizing agent. Contrast that with NADP+, which was an electron carrier in anabolic redox reactions. So NAD+ were primarily breaking things down, and NADP+ were primarily building things up. We're usually not seeing a whole lot of NADP+ in that form. We're mainly seeing it in the NADPH form as a reducing agent. So with NAD+, some of the catabolic reactions where we've encountered this before include glycolysis, pyruvate dehydrogenase, the TCA cycle, alcohol metabolism, lactate dehydrogenase, and beta oxidation of fatty acids. I won't walk you back through all those pathways, that would take all day, but if you've gone through the biochemistry unit chronologically, you should have encountered all these pathways by now. And then NADP+ and its partner NADPH participate in anabolic reactions like fatty acid synthesis, cholesterol and steroid synthesis. It's important for glutathione reductase as well as nitric oxide synthase. And then niacin's functions outside of its implications in NAD+ and NADP+ are in cholesterol metabolism. That's the other place you've seen this before. So So this is everyone's favorite diagram, the diagram of the lipid-lowering drugs. Don't get too bogged down for now. Here is niacin. Remember, it had two main functions. One was inhibiting hepatic VLDL synthesis, and those VLDLs were how cholesterol got exported out of the liver. And then niacin also inhibited hormone-sensitive lipase, which breaks down and liberates storage triglycerides into the bloodstream. So like we said, decreased VLDL synthesis and a decrease in hormone-sensitive lipase that decreases lipolysis. You can get vitamin B3 deficiency in a couple ways. Either a primary deficiency through decreased intake in cases of malnutrition or alcohol use. A vitamin B6 deficiency can also cause a niacin deficiency, because like we said, vitamin B6 is implicated in the synthesis of niacin in the body. And then similarly, disrupting the niacin synthesis pathway would be a tryptophan deficiency. Things like Hartnup disease or carcinoid syndrome. If you need a review on the pathophys of some of those things, check out the video on tryptophan, niacin, and serotonin. The clinical presentation of a niacin deficiency is going to be pellagra. Pellagra is characterized by the 3 Ds: dermatitis, dementia, and diarrhea. And the other thing you can see with the niacin deficiency is cerebellar ataxia. So pellagra especially is high yield for being able to identify a niacin deficiency. Specifically, pay attention to the dermatitis of pellagra. That dermatitis is going to be a cape-like rash, cape-like because it affects the C3 and C4 dermatomes. You might also hear it described like a collar. And you'll also see hyperpigmentation on the face and limbs. And we did already talk about this in our tryptophan metabolism video, so you've seen these images before, but here is that cape-like rash affecting the C3, C4 dermatomes. And you can see this picture of this girl over here. She has it too, as well as findings on her face and hands. Again, the video on tryptophan, niacin, and serotonin is going to give you a really great, even more in-depth explanation of all of these things. Let's talk now about vitamin B3 toxicity. Like I've been saying throughout this chapter, it's pretty hard to get a toxicity of a water-soluble vitamin because they don't build up in the body. You tend to see toxicity in the case of over-supplementation. Niacin is something that we supplement therapeutically as a cholesterol drug, and the therapeutic doses are pretty high, so you can see toxicity. Symptoms of vitamin B3 toxicity include flushing, which is prostaglandin mediated. You can see gout because of vitamin B3 toxicity leads to decreased uric acid excretion, and that hyperuricemia can lead to gout, as well as hyperglycemia. So like we said, niacin is therapeutically implicated in cases of hyperlipidemia. Niacin has a moderate LDL lowering effect, a moderate HDL raising effect, and a mild decrease in triglycerides. Niacin's not really a first-line drug. It's one of the better agents we have for raising HDL, but we have much better agents like statins for decreasing our LDL. And despite this somewhat favorable profile, niacin itself doesn't really decrease the risk for cardiovascular events the way things like statins have been proven to do. Additionally, very high doses of niacin are not necessarily recommended in patients who are already taking statins, and most people with hyperlipidemia are taking statins because those are our first-line agents. The adverse effects of therapeutic niacin are just going to be those symptoms of B3 excess like we talked about, the hyperglycemia, the risk for gout, and the flushing. Now, like we said, the flushing is prostaglandin mediated. So if you administer aspirin to patients who are suffering from this flushing at the same time that you give the niacin, you can combat the prostaglandin mediated flushing. Because of the effects of aspirin on the prostaglandin pathway, that should help to mitigate that flushing. So let's wrap this up. This has been a review of niacin, which is one of our water-soluble vitamins. And niacin gets metabolized into NAD+ and NADP+, which were powerful electron carriers across a whole array of redox reactions in the body, both anabolic and catabolic. Niacin was also involved in cholesterol metabolism via its ability to decrease lipolysis and VLDL synthesis. Those abilities make it a therapeutic option, albeit a second-line one, in hyperlipidemia, but be careful not to oversupplement or you may see some adverse effects like flushing, gout, and hyperglycemia. A vitamin B3 deficiency leads to pellagra, which is that characteristic triad of dermatitis, dementia, and diarrhea, as well as potential findings of cerebellar ataxia. And go check out the video on tryptophan metabolism for a review of those concepts. We're going to keep on moving through our water-soluble vitamins, so stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamin B6. Vitamin B6 is the next of the water-soluble vitamins that we'll be talking about in this chapter, and it comes from nuts, vegetables, whole grains, and meat. Those are your dietary sources of vitamin B6. Now, the important thing about vitamin B6 is that it is activated into a form called pyridoxal phosphate, or PLP. And PLP is critical. It shows up everywhere throughout the body as a cofactor for transamination reactions, decarboxylation reactions, glycogenolysis, and synthetic pathways. If you've been following along chronologically throughout this unit, we've encountered many of these reactions already and we'll be revisiting some of them in this video. So let's jump into some of those functions of vitamin B6 and its active form PLP. Remember, those functions are cofactor functions, and the first example we'll talk about is with transamination. We talked about transamination and AST and ALT in our chapter on protein metabolism. All right, so here's the diagram we looked at when we talked about ammonia transport, which featured the transamination reactions. Remember, protein degradation in the muscle led to the liberation of these amino groups, and that was a problem because that could generate toxic ammonia. So we utilized the process of transamination to pass this amino group down through a series of pathways to the urea cycle in the liver where it could be detoxified. These transamination reactions were responsible for loading these amino groups into and out from the alanine or the Cahill cycle. So AST and ALT were examples of those transaminases. And that transamination reaction, remember we said, requires a vitamin B6 cofactor. So that's one cofactor function of vitamin B6. The next we'll talk about are decarboxylation reactions. So decarboxylation reactions are reactions that remove a carboxyl group from a reaction in the form of carbon dioxide, CO2. One example that you've seen of this is the decarboxylation reaction that we see in neurotransmitter synthesis. For example, here's our neurotransmitter glutamate, and we can see vitamin B6 involved not only in the synthesis of glutamate from glutamine, as well as from alpha-ketoglutarate, but then also in the synthesis of GABA, another neurotransmitter, from glutamate. Here we can see vitamin B6 involved in the synthesis of another neurotransmitter, serotonin, which was coming from tryptophan. Again, you guys have seen this all before. How about our phenylalanine metabolism map, where vitamin B6 makes another appearance? Here in the synthesis of dopamine, which is also upstream of other neurotransmitters like norepinephrine and epinephrine. Vitamin B6 as a cofactor to dopa decarboxylase, again, critically important. So the synthesis of glutamate, the synthesis of GABA, the synthesis of histamine to histidine is another example of vitamin B6. Dopa to dopamine and tryptophan to serotonin are all neurotransmitter synthetic reactions that require vitamin B6, specifically because it is facilitating a decarboxylation reaction, right? All those decarboxylase enzymes like dopa decarboxylase that we've been talking about. And then outside of neurotransmitter synthetic pathways, those decarboxylation reactions are also important in heme synthesis. We talked about this last chapter with the porphyrias. Vitamin B6 was a cofactor for ALA synthase, which turned glycine and succinyl-CoA into ALA, aminolevulinic acid. We didn't really balance our reaction here, but coming out from this reaction would be CO2 as well as CoA. So this is a decarboxylation facilitated again by vitamin B6. And that ALA synthase was the rate-limiting enzyme for heme synthesis, making it even more important. B6 is also important in glutathione synthesis. We've talked a lot, even within this chapter, let alone this unit, about how important reduced glutathione is in battling oxidative stress in the body. Well, reduced glutathione is made up of glutamate and cysteine, and PLP, that activated form of vitamin B6, is a cofactor in the synthetic pathways of both glutamate and cysteine. We already talked about the synthetic pathway of glutamate. We saw already that vitamin B6 is involved. And in our chapter on one-carbon metabolism, we talked about the synthesis of cysteine. When we start with homocysteine, there are two enzymes involved in turning homocysteine into first cystathionine and then cysteine. The first is cystathionine beta synthase, the second is cystathionine gamma lyase, and both of those require vitamin B6 as a cofactor. And finally, vitamin B6 is involved in glycogenolysis, specifically as a cofactor for glycogen phosphorylase, which was this step right here that turned the branched glycogen into the limit dextrin by breaking off a G1P. So I told you guys, even though it seems like a lot, these are things that you've already seen before. We're just tying them all together. I know it's a lot of things, but if you just remember transamination, decarboxylation, and then the sort of two big families of those decarboxylation reactions being neurotransmitter synthesis and heme synthesis, glutathione and glycogenolysis, you'll be in good shape in remembering all of those different reactions as long as you learn them well. So let's talk now about vitamin B6 deficiency. Vitamin B6 deficiency, for whatever reason, is a very, very high yield. Vitamin B6 deficiency can come from a couple of different places, and it's very important to know all of these. It can come from malnutrition, as you may have guessed. It can also come from alcohol use, which is very high yield, and then it can be iatrogenic, so it can come from medications that we prescribe. One that is so high yield for whatever reason is isoniazid. Isoniazid being a tuberculosis drug. This can precipitate a vitamin B6 deficiency. This is another one of those ones where I'm not supposed to guarantee that stuff is going to show up in your exam, but if you ask me to put money on certain topics showing up, this could be in my top 3. That isoniazid, the tuberculosis drug, precipitates a vitamin B6 deficiency. Additionally, this could be an iatrogenic effect from the birth control pill. So what are you going to see clinically in a vitamin B6 deficiency? Peripheral neuropathy and seizures are going to be the major clinical presentation here, and that's because of the impaired synthesis of neurotransmitters. We just talked about how important vitamin B6 is in all of these different neurotransmitter synthetic pathways. When you're deficient in B6, that leads to neurologic trouble very quickly. Additionally, remember B6 is involved in heme synthesis. We talked a lot in our heme synthesis chapter about sideroblastic anemia and how one of the causes could be a vitamin B6 deficiency, where decreased ALA synthase activity because of the lack of cofactor leads to a decrease in heme synthesis. Decreased heme synthesis means less incorporation of iron into the synthesized heme, and that leads to iron being trapped in the mitochondria of erythroid precursors, right? Because remember, immature red blood cells still have mitochondria. We talked a lot about this in the last chapter on porphyrias, so I'm going to go through this kind of quickly, but just to remind you, some of our buzzwords here for sideroblastic anemia are basophilic stippling and ringed sideroblasts that you'll see in the bone marrow. First picture here shows you ringed sideroblasts. We have our erythroid precursors here, for example, and you can see all of these dots. This is the iron accumulation around that nucleus of these immature red blood cells. And then over here is the basophilic stippling, which is the accumulation of ribosomal RNA. Perhaps less common in a vitamin B6 deficiency. Again, go check out the video on sideroblastic anemia for more information. Sideroblastic anemia is usually microcytic and usually has a high serum iron in this case. Other clinical presentations of vitamin B6 deficiency include angular cheilitis, so irritation and cracking around the corners of the mouth, additionally glossitis, inflammation of the tongue, stomatitis, which is irritation to the oral mucosa, and seborrheic dermatitis. So lots of dermatologic findings as well. Your differential diagnosis for vitamin B6 deficiency should include vitamin B12 deficiency. The difference being that a vitamin B6 deficiency, like we said, is because of disrupted neurotransmitter synthesis, whereas a vitamin B12 deficiency is demyelinating. B6 deficiency is usually reversible. B12 deficiency, not so much if it's been going on for a long time. That demyelination often cannot be reversed. And whereas a vitamin B6 deficiency is commonly peripheral neuropathy and seizures, the neurologic findings of a vitamin B12 deficiency are going to be more in line with subacute combined degeneration, which are problems mainly with the dorsal column, so problems with proprioception, as well as the spinocerebellar and corticospinal tracts. We'll talk about that when we talk about B12 deficiency. Just know that if someone's off balance or ataxic and they have symptoms that you can localize to spinal cord tracts, that is less likely a B6 deficiency and more likely a B12 deficiency. So how are they going to test you on vitamin B6 deficiency, since it's pretty likely they will? Most commonly, they will give you a setup of a patient who is at risk for a B6 deficiency. They will be from one of these demographics. Most commonly, I would say either alcohol use or somebody who was just started on isoniazid. And they'll come in with some of these findings. Now you have to be careful because seizures and alcohol use could just be alcohol withdrawal, right? So you have to look at the whole clinical picture. But if they're testing B6 deficiency, they're likely to put together a constellation of things that point you in this direction. And then they like to frame the question like, this patient's presentation could have been prevented by administration of which of the following. And you should look for vitamin B6, or they might write out the actual word form pyridoxine. This is one that you should definitely know the other name for. Now, like we said, it's difficult to overdose on a water-soluble vitamin because they don't get stored in the body. But when we are administering things therapeutically in high doses, we can see toxicity. So in the case of oversupplementation of vitamin B6, you'll see peripheral neuropathy, dizziness, nausea, and photosensitivity. And the therapeutic uses, like I just alluded to, really the big one to know is that vitamin B6 is empirically supplemented on patients you start on isoniazid. So another way they could ask this question is they could make you diagnose somebody with tuberculosis, say that they're starting them on the first line treatment, either for latent or active TB, it doesn't matter, isoniazid is used in both regimens, and they'll say, in addition to the first-line treatment, what else should you supplement? They want you to know that the first-line treatment would include isoniazid and that you should supplement vitamin B6. Really burn that into your brain. So let's wrap this up. We've been talking about pyridoxine, or vitamin B6, another one of our water-soluble vitamins, which is activated into pyridoxal phosphate, PLP. This acted as a cofactor in lots of different high-yield reactions, transamination, decarboxylation reactions like in neurotransmitter synthesis and heme synthesis, glutathione synthesis, including reduced glutathione, our big warrior against oxidative stress, and glycogenolysis. And because vitamin B6 is implicated in so many of these different reactions, vitamin B6 deficiency is a very high yield test subject. In addition to getting this from malnutrition, you can also see it in alcohol use or as an iatrogenic consequence from the administration of isoniazid or the birth control pill. This presents with peripheral neuropathy and seizures, as well as sideroblastic anemia and some of these dermatologic findings as well. Deficiency sounds like a real nightmare, and it can be precipitated by isoniazid, one of our first-line tuberculosis drugs, so it should be supplemented empirically in patients who start that. And we said one of our differential diagnoses for a vitamin B6 deficiency was a vitamin B12 deficiency, which we're going to talk about in the next video as we keep on moving through these water-soluble vitamins. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamins B9 and B12. Vitamins B9 and B12 are both water-soluble vitamins, but interestingly, these are water-soluble vitamins that do have a storage supply within the body. Vitamin B9 comes from leafy greens, and enough of it is stored in the liver for about a 3 to 4 month reserve. We talked a lot about vitamin B9 on our chapter on 1-carbon metabolism. That was a whole chapter's worth of information, so it doesn't make a lot of sense to rehash the whole thing here, but the quick and dirty of it was that folate, or vitamin B9, could be activated to tetrahydrofolate, or THF. And that THF was a 1-carbon carrier, or a methyl group carrier, to provide carbons for the activated methyl group cycle, and was also involved in DNA and RNA synthesis. Here was our diagram for 1-carbon metabolism. Here was our dietary folate. We could see it was absorbed into the intestine and underwent a series of reactions to form tetrahydrofolate, which was a 1-carbon carrier, leaving us with N5-methyl THF, that methylated carbon-carrying THF that could enter the blood and go to the cells to participate in the activated methyl group cycle. That activated methyl group cycle was important in providing carbons for reactions like creatine synthesis, choline synthesis, epinephrine synthesis, DNA methylation, post-transcriptional modification, protein methylation, things like that. And you can go check out the chapter on 1-carbon metabolism for a refresher on those reactions. So that was our quick review of vitamin B9. Vitamin B12, on the other hand, comes from animal products, as well as a few fermented plants. Vitamin B12 is also made by colonic bacteria. However, the vitamin B12 that is created by colonic bacteria cannot be absorbed or used by the body. That's because vitamin B12 is absorbed in the terminal ileum, which is upstream. It's more proximal in the digestive tract than those colonic bacteria in the colon. And this absorption of B12 in the terminal ileum requires something called intrinsic factor, which comes from the parietal cells of the stomach. Vitamin B12 is also stored in the liver. However, there's enough B12 stored in the liver for about a 3 to 4 year supply, compared to the 3 to 4 month supply of vitamin B9. Vitamin B12 was also involved in the activated methyl group cycle. It was a cofactor for methylmalonyl-CoA mutase, and it also had secondary folate effects that we talked about again in our chapter on 1-carbon metabolism. In this video, we're going to dive a little deeper into vitamin B9 and vitamin B12 deficiencies, both very high yield. We'll start by talking about a B9 or a folate deficiency. This can come from malnutrition, malabsorption, pregnancy, or be iatrogenic, caused by certain drugs. The risk of a deficiency, especially one from malnutrition, is increased in a folate deficiency compared to a B12 deficiency because you have a much smaller reserve of vitamin B9 in your body compared to vitamin B12. Some iatrogenic causes of a folate deficiency include drugs like methotrexate, trimethoprim, sulfamethoxazole, and phenytoin. Let's talk about some problems associated with a folate deficiency. Well, a decrease in folate means a decrease in THF and all of the different forms of THF, including N5-N10 methylene THF. So let's take a look at this diagram. This diagram is a consolidation of a lot of the different diagrams that we talked about in the chapter on 1-carbon metabolism. Let's start by finding our vitamins B9 and our vitamin B12. Here is the folate cycle that we talked about, where folate becomes THF and then gets methylated and activated to join the activated methyl group cycle, which will be represented by this cycle over here. Up here you can see some of the reactions that happen in the mitochondria, including the reaction of methylmalonyl-CoA, which can go to join the TCA cycle. And you can also see the interplay between the folate cycle and DNA synthesis. So here's the diagram we're working with. Now, let's say that we have a decrease in folate. We have a folate deficiency. That means we're going to have a decrease in all of these downstream forms of THF. The first one we're going to hit on our way down is N5-N10 methylene THF. A decrease in N5-N10 methylene THF is going to mean a decrease in this reaction right here because we don't have enough of these starting reagents. And the reaction that I'm outlining is this one here at the intersection between the folate cycle and DNA synthesis, where we put in N5-N10 methylene THF and deoxyuridine, and we get out dihydrofolate and thymidine, which goes on to participate in DNA synthesis. So low folate means a problem in DNA synthesis. In addition, low folate is going to lead to decreased N5-methyl THF, one step further down the folate cycle from this methylene THF. And N5-methyl THF is the intersection between the folate cycle and the activated methyl group cycle. So we're going to have a decrease in this reaction mediated by methionine synthase in a folate deficiency as well. And that means decreased activity of the activated methyl group cycle, and as such, a buildup of homocysteine. Okay, so back to the outline. Like we said, a folate deficiency is going to cause a decrease in N5-N10 methylene THF, a deficiency in that. That'll cause a decrease in the synthesis of thymine nucleotides, which is important in DNA synthesis and DNA replication. When we have a problem with DNA synthesis, that creates a very specific kind of anemia called megaloblastic anemia. And go check out the hematology unit for all the details on megaloblastic anemia. But another important thing to know is that because DNA replication is being impeded upon in this folate deficiency, we'll also have an increased risk of congenital neural tube defects. You can think about how teratogenic it would be if we can't even replicate DNA in a fetus that is trying to grow and is requiring a ton of DNA replication. Additionally, a folate deficiency caused a decrease in N5-methyl THF, just another form of THF. That caused a decrease in methionine synthesis via methionine synthase. That was that step at the intersection between the folate cycle and the activated methyl group cycle. And as such, we had a buildup of homocysteine. Without running the activated methyl group cycle, we run into a lot of problems. Remember, we talked about all of the reasons why we need the activated methyl group cycle. No activated methyl group cycle means no DNA methylation, which is an increased risk for cancer. Remember, the mnemonic methylation mutes, right? DNA methylation helps turn off sections of DNA. Without that ability, we have an increased risk of cancer and aberrant replication. And we don't have those other synthetic pathways that the activated methyl group cycle facilitates, like creatine, choline, and epinephrine synthesis. Now, a vitamin B9 deficiency does not have any effect on methylmalonic acid. I only say that because when we talk about vitamin B12 deficiency, that's going to be a big difference between the biochemical implications of vitamin B9 and B12. So no effect on methylmalonic acid in vitamin B9. You may also see glossitis, but you will not see neurologic symptoms, which I only bring up because we are about to juxtapose this with vitamin B12. Let's talk now about a B12 deficiency. This can come from malabsorption. And remember, the absorption of B12 requires not only a functional terminal ileum, but also intrinsic factor, which means functional parietal cells of the stomach. So anything from atrophic gastritis to a gastrectomy to Crohn's disease that affects the terminal ileum can all cause malabsorption. Malnutrition can also cause a B12 deficiency, although like we said, it's less common to see a B12 deficiency versus a B9 deficiency in cases of malnutrition because you do have several years worth of storage. It would have to be a chronic problem. Additionally, pregnancy can cause a B12 deficiency, and there are also iatrogenic causes of a B12 deficiency. Not only drugs like metformin, proton pump inhibitors, or colchicine, but also procedures like a Roux-en-Y bypass, anything that's affecting those segments of the GI tract involved in absorption. Let's go back to our diagram now and talk about the clinical implications of a B12 deficiency. Vitamin B12, remember, is a cofactor for this enzyme here, methionine synthase. The enzyme that we just said is at the junction between the folate cycle and the activated methyl group cycle. In a B12 deficiency, we're going to shut down this enzyme and decrease the activity of both of these cycles. So everything that we saw with vitamin B9 is still in play. We have decreased activated methyl group cycle and all of its products. We have decreased DNA synthesis because of the effects on the folate cycle, right? We've effectively shut everything down and we end up sequestering all of our folate in this form here. It gets stuck and it can't move anymore past here in the cycle. And so everything grinds to a halt, including DNA synthesis. However, the difference now is we also have to take a look at these mitochondrial pathways, right? This methylmalonic acid business, because B12 was involved there, whereas B9 was not. Vitamin B12 being the cofactor for methylmalonyl-CoA mutase that turns methylmalonyl-CoA into succinyl-CoA, where it can run the TCA cycle. In a B12 deficiency, we knock out that step. We have a buildup of methylmalonyl-CoA and its byproduct, methylmalonic acid. So back to the outline, a B12 deficiency is going to cause a decrease in methionine synthase activity. That'll cause a decrease in the activity of the activated methyl group cycle. And so we'll see problems associated with that, which includes a decrease in not only DNA methylation, but also myelin synthesis. Let's put a pin in that myelin comment because that's something I'm going to come back to. And then we said the other cycle that is affected by this methionine synthase activity that requires vitamin B12 is it also shuts down the folate cycle and it traps folate in the N5-methyl-THF form. And because we're trapping all of that folate in the cycle in that form, you'll get what's called a secondary folate deficiency, where you're not actually deficient in folate, but all of it's trapped in a form and not being used. That also interfered with DNA synthesis, and because it interfered with DNA synthesis, we ended up with a megaloblastic anemia, just like we did in folate deficiency. So a common testing point that it's important to just jump in here and clarify quickly is that in both a B9 and a B12 deficiency, you will see a buildup of homocysteine. Right, here's homocysteine in our diagram. Regardless of whether we knock out B12 and we knock out the enzyme itself, or if we knock out B9 and we are sort of missing the folate part of it, in both cases we can't turn homocysteine into methionine. We've knocked out this step, so we'll get a buildup of homocysteine. So that lab is the same between vitamin B9 deficiency and B12 deficiency. However, only in a B12 deficiency will you see elevated methylmalonic acid, because only B12 is implicated in this methylmalonyl-CoA mutase enzyme. B9 has nothing to do with it. Those two lab values are the two that are, I would say, most commonly tested when testing B9 and B12 deficiency. Elevated homocysteine, not specific for one or the other, you'll see it in both, but the methylmalonic acid is only elevated in a B12 deficiency. Now, the difference between B9 and B12 deficiency is that in a B12 deficiency, you're going to see symptoms of neurotoxicity. The pattern is very specific. The pattern is called subacute combined degeneration, or SCD. And you can use the name SCD to help you remember what spinal cord tracts specifically are implicated in a B12 deficiency. You can think of the SCD as standing for spinocerebellar, corticospinal, and dorsal column. If you haven't learned the spinal cord tracts yet, I'm so sorry to be the one to introduce these to you. I've simplified it as much as I can just to the relevant pathways for this video. On the left here, we have our ascending pathways. These are sensory pathways that take signals from the periphery and send them up to your brain. They are ascending. On the right here, we have the relevant motor pathways. These are the descending pathways that take signals from your brain that tells your body to move and sends them down. So here's the posterior aspect of the spinal cord. Here's the anterior aspect of the spinal cord. And we're just looking at an axial cross-section across the spinal cord. Don't get confused by this posterior-anterior thing. It's not the same convention as like a CT scan. In subacute combined degeneration, these are the areas of the spinal cord that are affected. If you're starting to get overwhelmed, I'm going to give you the highest yield piece of information right now. The most commonly tested tract that is affected by a vitamin B12 deficiency is this dorsal column medial lemniscus pathway. For the sake of this video, all you have to know about that is it is a sensory pathway, and specifically the signals it carries are fine touch, proprioception, and vibration. However, the other sensory pathways that might be involved include these spinocerebellar tracts, which also have some proprioceptive effects as they pertain to balance. They control the ipsilateral side, so the same side. And then you may also see effects in the corticospinal tracts, which control voluntary movement of the contralateral side. You'll notice here that the spinothalamic tracts here, which control pain, temperature, and crude touch, these are spared. Okay, these are not affected by a B12 deficiency. Okay, so our three tracts that were affected were the spinocerebellar, the corticospinal, and the dorsal column, the most important being the dorsal column. Since the spinocerebellar tract was implicated in proprioception and the cerebellum, so balance, a problem with that is going to lead to ataxia, which is one of the clinical presentations of a B12 deficiency. The corticospinal tract was voluntary movement, so a problem with that can cause spastic paresis. And then the dorsal column was in charge of vibration absorption and proprioception. So we lose those things as well in a B12 deficiency. Like we said, we lose those things most commonly. The test for a loss of proprioception is the Romberg test, where you have patients stand with their feet together and you stand behind them to catch them if they fall, and you have them close their eyes. And once they close their eyes and they lose the visual input, their proprioception is impaired and they'll start to wobble and they won't be able to stand up. That's a test that they might describe to tell you that somebody's dorsal column has been knocked out. Now, B12 deficiency is not the only reason you would have a positive Romberg test. Neurosyphilis, so late-stage syphilis, causes a finding called tabes dorsalis, the dorsalis referring to the dorsal column. So you would also see a positive Romberg test in neurosyphilis. However, only the dorsal column is affected in neurosyphilis, in this tabes dorsalis. So involvement of either of the other two spinal cord tracts would point you towards a B12 deficiency instead, things like that ataxia and the spastic paresis. And again, you have to look at the whole clinical picture of what does this patient even have risk factors for. So the SCD were the three tracts that were affected. Pain and temperature were spared because the spinothalamic tract, which is more anterolateral within the spinal cord, was spared in this context of B12 deficiency. Okay, and remember I told you I was going to circle back to this point on decreased myelin synthesis. This is part of the neurotoxic effect of a B12 deficiency. But like we said, right, we would kind of see this process occur in a folate deficiency too. So why isn't a folate deficiency really neurotoxic like a B12 deficiency is? And that circles back to this point where the decrease in B12 also decreases the methylmalonyl-CoA mutase activity, right? Those were those pathways that were happening in the mitochondria, right? We said by knocking out this step, we were going to get a buildup of methylmalonyl-CoA and methylmalonic acid. That methylmalonic acid is a neurotoxic contributor. It interferes with not only myelin synthesis, but myelin maintenance. And therein lies the difference. So that is plenty on vitamins B9 and B12. Let's go ahead and wrap this up. Vitamins B9 and B12 are cousins that act together in a lot of different pathways, namely the activated methyl group cycle, DNA and RNA synthesis, homocysteine metabolism, the folate cycle, what have you. These were water-soluble vitamins, but they were unique in that there are storage reserves within the body. About 3 to 4 months for vitamin B9, 3 to 4 years in vitamin B12. We started by talking about vitamin B9 deficiency, which is more commonly due to malnutrition than vitamin B12 because of those storage reserves, and how a folate deficiency interfered with DNA replication, which led to megaloblastic anemia and neural tube defects. That's why folate is supplemented in pregnant women. And we also talked about the other pathways that are affected because of folate's implication in the activated methyl group cycle. However, vitamin B9, folate, did not have any effect on methylmalonic acid and did not have any neurologic symptoms. We went on to compare that to vitamin B12 deficiency, which did have those two things. Not only did we see a lot of the same things that we saw with a folate deficiency, with a B12 deficiency because of this secondary folate deficiency caused by reduced methionine synthase activity, but we also had neurotoxic effects, in part because of the buildup of methylmalonic acid that we got. And we talked about these specific findings that you see in a B12 deficiency, subacute combined degeneration, or SCD, which affected 3 spinal cord tracts, but most commonly the dorsal column, leading to a loss of position and vibration and a positive Romberg test. That's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on vitamins B2, B5, and B7. These vitamin deficiencies are really not as common as some of the other deficiencies we've been talking about. As such, they're also much less likely to be tested. I'm going to move through these pretty quickly and keep things pretty surface level because this is most likely all the details you'll need to know for the exam. So let's start by talking about vitamin B2 or riboflavin. This comes from flavoproteins, which are found in meat, eggs, fish, and milk, and these flavoproteins get turned into riboflavin in the intestine. There are 2 big active forms of riboflavin, or vitamin B2. These are flavin adenine dinucleotide, or FAD, and flavin mononucleotide, or FMN. Of the 2 of these, the more important one to know is FAD. That is because FAD is a cofactor to succinate dehydrogenase. Not only is succinate dehydrogenase one of the enzymes of the TCA cycle, but remember, the other name for succinate dehydrogenase was complex 2 of the electron transport chain. And so if there's one thing that you're going to commit to memory about vitamin B2, I would make it this line right here. Understanding that B2 in its active form is FAD, which is important to these processes. Vitamin B2 is also a component of glutathione reductase in erythrocytes, in red blood cells. The only reason I bring this up is because a decrease in erythrocyte glutathione reductase activity is diagnostic of a vitamin B2 deficiency. B2 was also a cofactor for some of those big enzyme complexes like the pyruvate dehydrogenase complex and alpha-ketoglutarate dehydrogenase complex. Remember, both of those had multiple cofactors, being B1, B2, B3, B5, and lipoic acid. A B2 deficiency would come from a dietary deficiency, and that would present as colitis, stomatitis, glossitis, so lots of inflammation, irritation around the mouth area. Corneal vascularization is another effect of this, as well as seborrheic dermatitis and a normocytic anemia. Unfortunately, a lot of these overlap with a lot of the other vitamin deficiencies, so you'll have to use other context clues within the question to help narrow things down. That being said, think very carefully before you choose a vitamin B2 deficiency as your answer on the STEP exam, just because it is much less common both on the test and in real life. The next vitamin we'll talk about is vitamin B5 or pantothenic acid. Your dietary sources of these are organ meats, broccoli, milk, and eggs. And the big important thing about pantothenic acid is it is one of the components of CoA. So you know how we have acetyl-CoA, succinyl-CoA, methylmalonyl-CoA, all these molecules attached to a CoA group. And I think up until this point I've let you get away with not really knowing what makes up CoA, and you can still probably get away with it, but for the sake of the lesson, CoA is pantothenic acid, so vitamin B5, plus cysteine and ADP. So vitamin B5 makes up that CoA group that is just scattered around our metabolism map in pathways like lipid synthesis, both fatty acids and cholesterol, as well as acetylcholine, the pyruvate dehydrogenase complex, and alpha-ketoglutarate dehydrogenase complexes as well. Remember we said B1, B2, B3, B5, and lipoic acid for those two. Those are all the main places that you've seen vitamin B5 throughout this unit. Vitamin B5 deficiency, exceedingly rare, especially in isolation, but when you do see it, it causes adrenal insufficiency, distal paresthesias, alopecia, and dermatitis. And we'll finish off by talking about vitamin B7 or biotin. Biotin comes from plant and animal products, plus a small amount that is synthesized in the intestine. And the function of vitamin B7 is it is a cofactor for all non-vitamin K-dependent carboxylases. So pretty much anything that we didn't talk about in the vitamin K video, but is a carboxylase, is mediated by biotin. So think back across the biochem unit for all of the carboxylation reactions that we've learned about, and I'll spare you having to actually think about that. I harvested some examples for you of reactions where we added a one carbon group that were not vitamin K dependent. So acetyl-CoA carboxylase is one example of this. We saw this in fatty acid synthesis. This turned acetyl-CoA into malonyl-CoA. Acetyl-CoA being 2 carbons, malonyl-CoA being 3 carbons. So we carboxylated that acetyl-CoA as part of our fatty acid synthesis pathway. Another example that I got for you is from gluconeogenesis. We learned about pyruvate carboxylase. This turned pyruvate, which was 3 carbons, into oxaloacetate, which was 4 carbons. That's a huge example, and that's a critical step in gluconeogenesis. One more example for you from our lesson on fatty acid degradation is propionyl-CoA carboxylase. This turned propionyl-CoA, which is 3 carbons, into methylmalonyl-CoA, which is 4 carbons. So I'll spare you from any more examples, but you're hopefully by now picking up the theme and also realizing, yes, you have covered all of this before. Now it's just time to really bring this stuff together. A vitamin B7 deficiency comes from malnutrition. It can also come from antibiotics because some B7 is synthesized in the intestines. If you give antibiotics that wipe out that intestinal flora, that can lead to a deficiency. And then one bizarre trivia fact for you to know, maybe not so much because it will show up on the STEP exam, but because attendings seem to love it as like a trivia question, is that raw egg white can cause a biotin deficiency. And this is because avidin, which is a component of the raw egg white, can bind the biotin and decrease its absorption from the GI lumen. I guess maybe they could test that if they give you a patient who's a bodybuilder who's eating a bunch of raw eggs all the time. But for whatever reason, attendings seem to love that fact, so maybe one worth knowing. A vitamin B7 deficiency would present as dermatitis, alopecia, conjunctivitis, enteritis, myalgia, as well as neurological symptoms like paresthesias or mental status changes. So let's wrap this up. We've been talking about some of the more forgotten B vitamins, forgotten because their deficiencies are just less common. The big thing to remember about vitamin B2 was that one of its active forms was FAD, which played a heavy role with succinate dehydrogenase in the TCA cycle, as well as its function as complex 2 in the electron transport chain. Vitamin B5 was important because it was one of the constituent components of CoA, which we see everywhere across our metabolism map. And vitamin B7 or biotin was important because of its involvement in the non-vitamin K-dependent carboxylase reactions. We found examples in fatty acid synthesis, gluconeogenesis, and fatty acid degradation, as well as our tidbit that raw egg white can cause a biotin deficiency. And with that, that is all of the vitamins we're going to be talking about. We have one more video on trace elements, which we'll get to next, so stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige, and thank you so much for joining me for our lesson on trace elements. So while this is a chapter on vitamins, and technically trace elements are not vitamins, they are in fact minerals, I didn't really know where else to put this video, so we're going to talk about them here. These trace elements are dietary minerals that are required in small amounts. We need them because of their function as cofactors or else as constituents of larger molecules. We're going to be talking very quickly about just the highest yield elements, zinc, copper, iron, and iodine. Each one of these elements could be their own massive chapter, what with all of their implications, but most of these things are covered elsewhere on the site. Some of them earlier on in the biochemistry unit, some of them in other units across boot camp. Use this as a refresher and as a review, and anything you aren't familiar with, you can go elsewhere on the site to brush up. So like I said, the big ones we'll be talking about are zinc, copper, iron, and iodine, but some other good trace elements to at least be aware of include sulfur, selenium, chromium, fluoride, manganese, and cobalt. Those ones weren't quite important enough to make the cut for this video, but if you have no idea what those things do, it might be worth just going and looking them up, just giving them a once-over. That's all you'll probably need. Let's start by talking about zinc. The topic of zinc doesn't necessarily come up on every single exam, but it does come up much more often than you might expect. It's definitely worth being familiar with. And the big function of zinc that they especially like to test is something called the zinc finger. The zinc finger is a transcription factor motif. This is one of those things that I really did not understand at all until I saw a weird picture like this. If you look here, we have a string of amino acids. You can see emphasized along this chain are the cysteine and histidine residues. And in the middle here, we have zinc. So you can see this amino acid chain is forming sort of this loop around our central zinc. In the case of the zinc finger, what's going to happen is along this loop of amino acids, the cysteine and histidine residues are going to coordinate with this zinc ion here, and the zinc will hold the residues in place in a way that favors the formation of this finger-like projection. So this structure is being supported by these anchors here around the zinc. And this finger-like projection, or the zinc finger, can interact with DNA and RNA and proteins. And as such, the zinc finger helps to facilitate very precise regulation of gene expression. So that's all the zinc finger really is. The zinc bonds with cysteine and histidine residues in a way that stabilizes a finger-like projection, promoting the structural integrity of different transcription factors. Now, zinc also has some other functions, namely as a cofactor. Zinc is a cofactor for collagenases, the angiotensin converting enzyme, or ACE, DNA polymerase, carbonic anhydrase, ALP, or alkaline phosphatase, and superoxide dismutase. And again, each of those enzymes could be their own lesson, so if you're not familiar with them yet, just circle back when you are. Now, a zinc deficiency is not uncommon to encounter on the STEP exam, believe it or not. It's characterized by impaired wound healing, as well as alopecia, dermatitis, diarrhea, immune dysfunction, and sensory deficits. So things like dysgeusia or anosmia, problems or changes in taste and smell. The real triad for zinc here is alopecia, dermatitis, and diarrhea, but I would also make sure that you know the wound healing aspect as well. One condition associated with some of these things is something called acrodermatitis enteropathica, which is a congenital deficiency of the zinc transporter leading to a presentation of a zinc deficiency. Zinc excess, less commonly tested, mostly just associated with GI upset. Let's move on now to copper, and you've learned a lot about copper already if you watched the video on Menkes disease. So we're going to go through it pretty quickly. Copper forms ceruloplasmin as well as superoxide dismutase. Ceruloplasmin, which we talked about in the video on Menkes disease, is important in iron metabolism as well as an antioxidant. And superoxide dismutase we spoke about when we talked about the respiratory or oxidative burst. Copper is also important because it's a cofactor for things like cytochrome C oxidase, known more colloquially as complex 4 in the electron transport chain, as well as things like tyrosinase, lysyl oxidase, and factor V. Remember, these were from phenylalanine metabolism, the collagen synthesis pathway, and this is from the coagulation cascade. The most common way that they'll test a copper deficiency is by testing Menkes disease. And again, I encourage you to go check out that video to really help tie things together. Here was the picture that we used when we talked about Menkes disease, and the big giveaways for recognizing this were the kinky hair that was also sparse and brittle, as well as skin and hair hypopigmentation. Other clinical manifestations of a copper deficiency include sideroblastic anemia, neurologic symptoms like ataxia and neuropathy, as well as delayed wound healing. All these presentations are coming from a deficiency of the cofactor of all of these important biochemical agents. And then an excess of copper, also commonly tested on STEP, is Wilson disease. And that's a combination of neurologic and hepatic findings, as well as the Kaiser-Fleischer rings. If you're not familiar with Wilson disease, definitely go check out the content on it elsewhere on the site. Next trace element we'll talk about is iron. And you're all familiar with iron by now. It forms hemoglobin as well as myoglobin. It is a cofactor for important things like cytochrome C in the electron transport chain, involved in a ton of different drug metabolism, and metalloproteins like NADH dehydrogenase. And iron deficiency leads to the classic iron deficiency anemia, generally microcytic and hypochromic. Again, we have whole videos on iron deficiency anemia. And an excess of iron is generally tested as hemochromatosis, clinically presenting as bronze diabetes, meaning the patient is hyperpigmented or tan, has endocrine dysfunction leading to diabetes, as well as other symptoms like liver cirrhosis and adrenal insufficiency. And these things are caused by iron deposition in the tissues. So here's a picture of some liver histology, and you can see the hepatocytes, and you can see these coarse yellow-brown granules everywhere within the cytoplasm of the hepatocytes. All these brown dots here, and that is hemosiderin, which is an iron storage complex. So that's basically iron deposited in these liver cells. That's a histology image they might show you if they're testing hemochromatosis. All right, the last trace element to know is iodine. Iodine you guys are familiar with from the endocrine chapter. This forms thyroid hormones like T3 and T4. Because of that role, a deficiency of iodine is going to lead to hypothyroidism, potentially a goiter as the thyroid gland expands to try and make more thyroid hormone, but it can't because it's missing that fundamental iodine. And while a deficiency of iodine can lead to hypothyroidism, an excess of iodine usually does not have any sort of effect in a normal thyroid's functioning. That's because of something called the Wolff-Chaikoff effect. The Wolff-Chaikoff effect is a protective effect where your body protects you from high amounts of iodine by decreasing thyroid hormone synthesis. This leads to a transient hypothyroidism, and in that way temporarily protects you in a state of low thyroid function through the surge of iodine. That's what happens in a normal thyroid. However, in someone with a pre-existing thyroid abnormality, you might instead see something called the Jod-Basedow phenomenon. So in someone with a pre-existing thyroid problem, when they encounter a period of high iodine in their body, their thyroid abnormality means that they don't have that protective Wolff-Chaikoff effect. Instead, the increased iodine will actually increase their thyroid hormone synthesis. So they'll take all that iodine that's coming in and they'll synthesize thyroid hormone with it, as opposed to suppressing that synthesis. And in those patients, that will lead to hyperthyroidism. Like we said, though, that won't be a problem in patients with a normal, healthy thyroid. All right, so let's wrap this up. We've been talking about trace elements, which are dietary minerals that are required in small amounts, either as cofactors or constituents of larger molecules. We talked about zinc and how it forms the zinc finger, which helps to promote the structural integrity as well as the gene expression precision regulation of transcription factors. And a zinc deficiency leads to impaired wound healing as well as the triad of alopecia, dermatitis, and diarrhea. Copper was important because it helped form ceruloplasmin as well as superoxide dismutase and had lots of important functions as a cofactor. And we quickly revisited the topic of Menkes disease, which is the most common way that they'll test a copper deficiency, as well as Wilson disease, which is the most common way that they'll test an excess of copper. Then we talked quickly about iron. We didn't really do it justice so much in our conversation, but we just revisited some topics like the important cofactor functions of iron, some quick characteristics of an iron deficiency anemia, and we talked about hemochromatosis, which is a common way that they will ask about iron excess. And then finally, we talked about iodine, which is important because it makes up thyroid hormones. An iodine deficiency can lead to hypothyroidism, but in healthy people, an iodine excess is not too much of a problem because of the Wolff-Chaikoff effect. And there you have it. That is it, not only for this chapter, but for the entire biochemistry unit. What a pleasure. It has been a labor of love. I hope you guys learned something. Good luck to all of you on your STEP exams and your careers beyond. If you have any questions, comments, concerns, problems, troubles, worries, hopes, dreams, fears, send them on my way. Otherwise, good job, good luck, and keep practicing. All right, go ahead, take a minute, read through the question, and then we'll come back together to talk about the answer. All right, so we have a 25-year-old man who's coming to the clinic with progressive difficulty walking and frequent tripping over the past several months. He's reporting a pins and needles sensation in his feet and increasing difficulty with balance, especially in the dark. So this patient has several different manifestations of neurologic dysfunction. He's also noting an unintentional 10-pound weight loss over the last few months, and he has a medical history of Crohn's disease. It's generally well controlled with infliximab, though he has intermittent flares requiring systemic corticosteroids. And he has a surgical history, including a small bowel resection a year ago. So between the unintentional weight loss, the Crohn's disease, and the small bowel resection, he has both risk factors for and some beginning findings of fat malabsorption. On physical exam, we're going to see some more neurological symptoms. We've got decreased vibratory sensation and proprioception in both lower extremities, absent deep tendon reflexes at the ankles, and a wide-based gait. Lab studies are showing a hemoglobin of 10.1, but with a normal mean corpuscular volume. So that, to me, I would characterize as a normocytic anemia. And furthermore, with the finding of a decreased serum haptoglobin, I would consider this to be a hemolytic anemia. If you don't know what haptoglobin is, it is a glycoprotein that is produced by the liver that floats around in the blood and basically binds to free hemoglobin in the blood. So when a red blood cell lyses or explodes, it will release its hemoglobin, and that free hemoglobin in the blood can cause oxidative damage. So haptoglobin is created to bind it and help clear it through the reticuloendothelial system, so the spleen and the liver mainly. So when there is a hemolytic anemia, or red blood cells are exploding a lot more than usual, that excess of free hemoglobin from the exploded cells will be bound up by haptoglobin. And so haptoglobin will be depleted. And so low haptoglobin is a hallmark hemolysis lab. So if you want to know whether a patient's anemia is hemolytic, that's one of the labs you can get. But you want to remember that it's the low value that is the red flag. So we have a normocytic hemolytic anemia. The prothrombin time is normal, so we're not worried about a coagulopathy necessarily. And those serum triglycerides are pretty low. And that can be another thing that points us towards fat malabsorption. And finally, we have a normal serum homocysteine, and we'll get to the relevance of that as we talk through our incorrect answers. The question wants to know which of the following findings is most likely to be present, and the answer is acanthocytosis. And that is because this patient's neurologic symptoms and normocytic hemolytic anemia in the context of fat malabsorption points us towards a vitamin E deficiency. So vitamin E is one of the 4 fat-soluble vitamins, which are vitamins A, D, E, and K. And more broadly, fat-soluble vitamin deficiency can happen in conditions of fat malabsorption. So things like Crohn's disease, especially with a small bowel resection. Crohn's disease itself can lead to fat malabsorption, but this can be compounded by a resection where you just fully remove a large area within the bowel that would otherwise be used for absorbing fat. Other conditions where you can see fat malabsorption and therefore deficiencies of fat-soluble vitamins include things like cystic fibrosis, chronic pancreatitis, as well as celiac disease. So the symptoms of a vitamin E deficiency are 1, neurologic symptoms, and that is because vitamin E deficiency affects the posterior column and the spinocerebellar tracts. These are neurological tracts. If you haven't covered neuro yet, don't panic. We do a crash course on it when we talk about vitamins B12 and vitamin E, so you can go ahead and check out those videos for a refresher. But basically, losing these tracts leads to ataxia and loss of proprioception. Proprioception is the understanding of where your limbs are in space. And we noticed that our patient's difficulty with balance was especially prominent in the dark. And so when you're getting visual input, it's kind of easy to compensate for a poor proprioceptive sense. That's why something like the Romberg sign is very helpful. The Romberg sign, where you have patients stand with their feet together and close their eyes, and then when they close their eyes and they lose that visual input, that's sort of helping them to overcome their proprioceptive deficits, then they start to wobble. And then the other thing you can see with a vitamin E deficiency is a hemolytic anemia. Vitamin E protects against oxidative damage, right? We talked a lot about the elaborate pathway by which it does this in the vitamin E video. Without vitamin E, there's no protection against free radical damage, and the red blood cell membrane loses stability. And that leads to a finding called acanthocytosis. So when the reactive oxygen species damage the red blood cell membranes, you end up with these sort of spiky, unstable red blood cell membranes that ultimately just end up in the red blood cell lysing, hemolyzing. So our answer is A, acanthocytosis. acanthocytosis. But let's talk about why some of these other answer choices are incorrect. Because a vitamin E deficiency looks a lot like some other vitamin deficiencies that you may have confused this with. Answer choice B, decreased reticulocyte with ringed sideroblasts, is seen in a B6 deficiency or a pyridoxine deficiency, which can lead to something called sideroblastic anemia. A B6 deficiency can cause peripheral neuropathy, but it doesn't usually cause that posterior column defect. Other findings associated with a B6 deficiency include seborrheic dermatitis, angular cheilitis, glossitis, stomatitis, that kind of thing. And the anemia in a B6 deficiency is usually microcytic, so it would not have this normal mean corpuscular volume, and it's not a hemolytic anemia. And additionally, vitamin B6 is not a fat-soluble vitamin. We do have clues that we're looking for a fat-soluble vitamin here because of this fat malabsorption sort of picture that we saw with the low triglycerides and the unintentional weight loss. Although vitamin B6 deficiency is not an unreasonable thought because vitamin B6 is absorbed in the small bowel and this patient did have a small bowel resection. Ultimately though, because we have posterior column dysfunction and a hemolytic anemia, we don't have those other dermatologic findings that we sometimes see with a B6 deficiency. I'm just overall less convinced by option B, so I'm gonna rule that one out for now. Options C and D both represent a vitamin B12 deficiency, though option D could also represent a vitamin B9 deficiency. In general, for a vitamin E deficiency, our biggest differential is a vitamin B12 deficiency. B12 deficiency also affects the posterior column and spinocerebellar tracts. And it also causes anemia, though it causes a different kind of anemia, which I'll talk about in a second. And a B12 deficiency can also be seen in patients with Crohn's disease, status post a small bowel resection, as vitamin B12 is absorbed exclusively in the ileum, where it binds to intrinsic factor for reuptake. So the key lab findings that we're looking at to differentiate vitamin E from a vitamin B12 deficiency is 1, this serum triglycerides, and the unintentional weight loss are pointing us towards a fat-soluble vitamin deficiency, although of course multiple things could be going on. Another thing to look at is the mean corpuscular volume. A vitamin B12 deficiency is normally a megaloblastic anemia, which just means a macrocytic anemia, where the red blood cells are larger than average, also characterized by hypersegmented neutrophils. This patient has a normal mean corpuscular volume, meaning the red blood cells are of a normal size. So this is less likely to be a megaloblastic anemia. And additionally, the low haptoglobin tells us that we have a hemolytic anemia, which is again not characteristic of B12 deficiency. Additionally, both vitamin B9 and B12 deficiencies are usually accompanied by an elevated serum homocysteine. In B12, you also see an elevated methylmalonic acid. We talked about that in our B9 and B12 video. It's because both vitamin B9 and B12 are involved in the activated methyl group cycle. The normal serum homocysteine points us way away from vitamins B9 and B12. And so even if you haven't studied hematology yet and you didn't know anything I said about haptoglobin and MCV and anything like that, based on the homocysteine alone, you should have been able to rule out your most promising differential diagnosis, which was a vitamin B12 deficiency. I'll give you sort of a final test-taking tip. Because answer choice C and D both would have been correct in a vitamin B12 deficiency, it wouldn't have been able to choose just one correct answer if this patient in fact did have a vitamin B12 deficiency. Because if this were a B12 deficiency, both elevated methylmalonic acid and hypersegmented neutrophils would be expected findings. Since we can only pick one option and both of these choices could apply to a B12 deficiency, it's more likely that neither is the correct answer. You can rule them both out. And then answer choice E, prolonged partial thromboplastin time, or PTT. This would be seen in a vitamin K deficiency, which is a fat-soluble vitamin, because vitamin K deficiency causes impaired clotting factor production, specifically the vitamin K-dependent coagulation cascade factors 2, 7, 9, and 10. So vitamin K deficiency usually leads to bleeding symptoms as opposed to these neurologic symptoms that we're seeing here. It also doesn't lead to hemolysis, or the exploding of those red blood cells. It's more a problem with the clotting. Now, in a vitamin K deficiency, prothrombin time, or PT, is usually affected before PTT. And I won't get into the whole coagulation cascade, that's way outside the scope of this video. Just know that of the vitamin K-dependent coagulation factors, factor 7 has the shortest half-life. And factor 7's activity is reflected by the prothrombin time. So if we didn't see any changes in the PT, which we don't, then we wouldn't expect to see any changes in the PTT. PTT is generally a later finding. That's a testing point that deceptively comes up all the time. If you can remember that factor 7 has the shortest half-life, that will actually get you a long way. Just sort of a side learning point though. In general, this clinical picture is not in line with a vitamin K deficiency, so that's out. So in summary, vitamin E deficiency occurs in fat malabsorption syndromes. Neurologic symptoms of a vitamin E deficiency can mimic a vitamin B12 deficiency. And so you can see things like ataxia and proprioceptive loss, but you do not have a megaloblastic anemia in a vitamin E deficiency. Instead, you have a hemolytic anemia because vitamin E protects red blood cells from reactive oxygen species damage. And the finding we see on a peripheral smear is called acanthocytosis, where you get those spiky red blood cell membranes. And the key labs for differentiating a vitamin E deficiency from a B12 deficiency are that in a vitamin E deficiency, you'll see that decreased haptoglobin from hemolysis, a normal methylmalonic acid and homocysteine, and a normal mean corpuscular volume. Whereas in a B12 deficiency, you'll see elevated homocysteine and methylmalonic acid, and you'll see a megaloblastic anemia, which is characterized by an elevated MCV and hypersegmented neutrophils. And that's all I got for you. Good job, good luck, and keep practicing.